Escherichia coli, whereas the most common cause for amoebic liver abscess, as we discussed, it was entamoeba histolytica. It was entamoeba histolytica, right? Important. Now, please write me to the most common site. So please remember the most common site for amoebic liver abscess. This is important. The most common sites for the amoebic liver abscess, it is usually which lobe? Most of you are answering caudate lobe. Please remember, it is not the caudate lobe. Caudate lobe kaun sa hota hai? So if I talk about the Coynard's classification, okay, if I talk about the Coynard's classification, so the Coynard's classification divides liver into how many segments? It divides liver into 8 segments. Okay, surgically, liver is usually divided into 2 lobes. That is the right and left lobe. Okay, so please remember, liver is divided into 2 lobes, right and left lobe, with the help of Cantley's line. Right, liver is divided into right and left lobe with the help of Cantley's line. And this Cantley's line important hai, question aa sakta hai. It extends from the gallbladder fossa till the inferior vena cava. It extends from the gallbladder fossa till the inferior vena cava. And this Cantley's line divides the liver in how many lobes? 2 lobes. That is your right and left lobe. But if I talk about Coynard's classification, it divides the liver into 8 segments, right? So these are all your 8 segments, okay? And thus the middle one that is there, okay, which is inside the liver, okay, the inside one, it is called as the first segment, and this first segment is also called as the caudate lobe. Yaad rakhna, the first segment is also called as the caudate lobe. Yeah, please remember this, okay? And this is not involved in cases of amoebic liver abscess. In amoebic liver abscess, usually it is the which lobe? It is the right lobe which is commonly involved. Which lobe is involved? It is the right lobe which is involved. And which quadrant is involved? Posterior-superior quadrant. Which quadrant? Posterior-superior quadrant. As you can see, the 7th and the 8th quadrant would be involved over here, okay? The 7th and the 8th quadrant would be involved. Posterior-superior quadrant in right lobe of the liver are usually involved in cases of amoebic liver abscess. Clinical features kya honge? Definitely the patient will have fever vagera, okay? So please remember, the patient will have fever in this condition. There would be right abdominal pain or right upper quadrant pain, as we can say, or right hypochondrium pain, whatever you call it, okay? So right upper quadrant pain, there would be fever in the patient, nausea and vomiting ho sakta hai in the patient, okay? And the patient will appear more toxic. Okay, the patient will appear more toxic in this condition. No issues with this? Yeah. What is the investigation of choice? Anybody? What is the investigation of choice? Please let me know. Investigation of choice would be? Very good. Investigation of choice would be a ultrasound. Investigation of choice. मैंने क्या बोला है? Anywhere if there is fluid, okay? Anywhere if there is fluid, okay? So fluid का friend कौन होता है? Ultrasound. So please remember, usually it is the ultrasound abdomen. It is usually the ultrasound abdomen. And if you need to confirm the diagnosis, okay, ultrasound abdomen is the investigation of choice. And if you need to confirm the diagnosis, then you can perform serology. Okay, no issues with this. Treatment now for pyogenic liver abscess, definitely if it is an abscess, we need to drain it, but incision and drainage is not done. Rather a percutaneous drainage is done. Okay, rather a percutaneous drainage is done. And this percutaneous drainage is done with which catheter? As I told you, as we discussed for pancreatic pseudocyst also, it is done with this catheter. Important hai? Okay, so this looks like a pigtail, and therefore it is called as a pigtail catheter. Important in surgery, usually they will also ask you about the instruments, so please remember, okay? So this is what is a pigtail catheter looks like, okay? It looks like a pigtail, therefore it is known as a pigtail catheter, and pigtail catheter is used for percutaneous drainage from the liver abscess. No issues with this, yaad rakhna. Amoebic liver abscess is also usually, amoebic liver abscess can be drained, okay? If it is large in size, it can be drained, but usually it is drained only in later cases when it is very huge in size. Otherwise, it can be treated with a drug. What is the drug of choice for amoebic liver abscess? Anybody? The drug of choice for amoebic liver abscess. Jaldi se. Very good. It is metronidazole. The drug of choice for amoebic liver abscess is metronidazole. Drug of choice for amoebic liver abscess is metronidazole. So metronidazole is given to the patient, and most of the patients will recover. If the patient does not recover, in that condition, we will need a percutaneous drainage with pigtail catheter. Otherwise, it is not required. So then if I talk about this, what is this? Here you can see a pus which is seen in cases of amoebic liver abscess. This pus characteristically has a name. It looks like chocolate, or it looks like a sauce known as. So this is what is known as a anchovy sauce pus. This is what is known as a anchovy sauce pus, or sometimes some books also call it as the chocolate pus. So anchovy sauce pus or chocolate pus is seen in conditions of amoebic liver abscess. Okay, anchovy sauce pus or chocolate pus is seen in conditions of amoebic liver abscess. And please remember, amoebic liver abscess is usually associated with alcohol intake. Okay, so male individual who is a chronic alcoholic can present to you with features of amoebic liver abscess. Okay, yaad rakhna. No issues with this. And please tell me which is the most common organ affected in amoebiasis. Entamoeba histolytica most commonly infects which organ? Entamoeba histolytica in pregnancy usually infects which organ? Please let me know. Entamoeba histolytica in pregnancy infects which organ? Sorry, Entamoeba histolytica in amoebiasis infects which organ? Just a minute. क्या हो गया? So please remember, it is no. The most common site of amoebiasis. Very good, Niveta. It is colon or intestine. याद रखना, the most common site for amoebiasis is the intestine. Don't get confused with this one. Okay. So the most common site for amoebiasis is usually the intestine. From intestine, it will spread up to the liver. याद रखना, from intestine, it will spread up to the liver. It is usually the intestine. And in intestine, in cases of intestinal amoebiasis, which kind of ulcers are seen in the intestine? In cases of intestinal amoebiasis, this kind of ulcers are seen. What these ulcers are looking like? So these kind of ulcers are seen usually in cases of intestinal amoebiasis. Very good. These are known as the flask-shaped ulcers. These are known as the flask-shaped ulcers. So please remember, in intestine, multiple ulcers can be seen. Yaad rakhna, transverse ulcers are seen in tuberculosis. Okay, transverse ulcers are seen in tuberculosis. Longitudinal ulcers are seen in typhoid. Longitudinal ulcers are seen in typhoid, whereas flask-shaped ulcers are seen in intestinal amoebiasis. Flask-shaped ulcers are seen in intestinal amoebiasis. No issues with this, yaad rakh lo. Then if I talk about the next condition, that is what is your hydrated cyst. So please remember, somebody was asking about pregnancy. Please remember, in pregnancy, if we need to avoid metronidazole, we can give other drugs like ceftriaxone vagara. Okay? So these are safer, like broad spectrum antibiotics would be given to the patient usually. If I talk about hydrated cyst, the most common cause or the most common organism responsible for hydrated cyst is known as aphthous ulcers. Can be seen in multiple conditions. See, aphthous ulcers are usually the initial manifestations of Crohn's disease also. They can also be seen in cases of SLE as well. Okay, sometimes. But usually they are associated with Crohn's disease, aphthous ulcers. Okay. Very good. It is Echinococcus granulosus. So please remember, the most common cause of hydrated cyst is Echinococcus granulosus. It is a parasite known as Echinococcus granulosus. Okay, most common cause of hydrated cyst is a parasite known as Echinococcus granulosus. And the most common organ affected over here would be liver. Yahan pe it is liver. Okay, most common organ affected over here is liver. Okay, and hydrated cyst, Echinococcus granulosus causes what? It causes accumulation of fluid and it causes cyst in multiple organs. Okay, these cysts can be seen in multiple other organs, but the most common organ affected is liver. Most common organ affected with hydrated cyst is liver. Please tell me, Echinococcus granulosus is also known as which tapeworm? The definitive host of Echinococcus granulosus. Anybody? Jaldi se. Jaldi micro. The definitive host of Echinococcus granulosus. Very good. It is dog, and therefore Echinococcus granulosus is also known as dog tapeworm. It is also known as dog tapeworm. The intermediate host is usually sheep. Okay, intermediate host is sheep, whereas the accidental intermediate host is man. Accidental intermediate host is man. What is the investigation of choice? Here also the investigation of choice. First line investigation would definitely be an ultrasound. Okay, first line investigation can be an ultrasound, but to confirm the diagnosis, we need to do a CECT abdomen. So the investigation of choice would be a CECT. ERCP nahi karenge. Investigation of choice would be a CECT abdomen. And as you can see over here in the CECT abdomen, which sign is seen on the CECT abdomen? Which sign is seen? Very good. It is the water lily sign. It is the water lily sign. Okay. Water lily sign. Along with this, you can see in the cyst, there is a membrane which is there. Okay. So a floating membrane which is seen. And this floating membrane is also looks like a snake, and therefore it is also known as the serpent sign. Therefore, it also known as the serpent sign. So, which two signs are seen on CECT of hydrated cyst? First is the water lily sign. First is the water lily sign. Second is the serpent sign. Second is the serpent sign. I request you, jahan pe bhi baithe ho, wherever you are, please keep repeating these things. Though we are not in class, but it is important to repeat these things a number of times so that then the chanting would be useful to you. Okay, no issues with this. Yaad rakh lo. What is the treatment? Anybody? The treatment for hydrated cyst. There is a therapy and it has a characteristic name. What is this therapy known as? Anybody? The treatment of choice for hydrated cyst. What is the therapy known as? Very good. It is known as the pair therapy. It is known as the pair therapy. What do we mean by pair therapy? So please remember, pair therapy is usually percutaneous aspiration. So this fluid should be percutaneously aspirated. Then there should be injection. Injection of which agent? Injection of scolicidal agent. Okay, injection of scolicidal agent, and then reaspiration of these agents. Okay? So percutaneous aspiration, injection of spolicidal agents, and then reaspiration. That is what is a pair therapy. And pair therapy is the treatment of choice for hydatid cyst. Pair therapy is the treatment of choice for hydatid cyst. Which organ is never affected with cyst? Okay, which organ is never affected with cyst? Jaldi se. Which organ is never affected with hydatid cyst? Or you can say least common or rare. Second most common is lungs usually. Very good. It is a brain. Brain is never affected with hydatid cyst. Yaad rakhna. No issues with this. Now, if I talk about the most common malignancy of liver, anybody, what is the most common malignancy of liver? Again, answer remains same. Most common malignancy of liver would be most common malignancy of liver, guys. Most common very good. It is metastasis. Most common malignancy of liver is metastasis. Most common malignancy of liver is metastasis or secondaries. Okay, most common malignancy of liver is metastasis or secondaries. Most common primary malignancy would be most common primary malignant tumor or most common primary malignancy of liver. The answer would be most common primary malignancy of liver. The answer is very good. It is HCC. That is your hepatocellular carcinoma. The most common primary malignancy of liver is hepatocellular carcinoma. Most common primary malignancy of liver is hepatocellular carcinoma. As we already discussed, hepatocellular carcinoma is seen in groundnut industry workers. Okay, thoda sa PSM recall, and it is due to a condition known as aflatoxicosis. So HCC can occur due to aflatoxins. Okay, yaad rakhna. Then if I talk about the most common primary tumor in children, most common primary tumor in children usually. Most common primary liver tumor in children. It is a malignant tumor. Most common primary malignant tumor in children. Anybody? Jaldi say. Most common primary malignant tumor in children. It is known as hepatoblastoma. It is known as hepatoblastoma. Please remember the most common primary malignant tumor in children is hepatoblastoma. Most common primary malignant tumor in children is hepatoblastoma. Whereas the most common benign tumor of liver. Most common benign tumor of liver would be most common benign tumor of liver. Most of you will mark it as hepatic adenoma. Don't do that. Very good, Nivita. It is hemangioma. Most common benign tumor of liver is hemangioma. Most common benign tumor of liver is hemangioma. एक थोड़ा सा related question बता दो जल्दी से. Hemangioma in vertebra causes which appearance? Hemangioma, if it is seen in vertebra, causes which appearance? Ortho से important. ठीक है? So most common hepatic benign tumor is usually a hemangioma. ठीक है? Whereas if I say a young female is having, and please remember, liver tumors are usually common in females. Liver tumors are usually common in females. याद रखना. If I say a young female was taking OCP, okay, a young female was taking oral contraceptive pills, she is at an increased risk of which hepatic tumor? She is at an increased risk of which hepatic tumor? पहले ये बता दो, then मैं वो vertebra वाला बता दूँ. So young female with OCP intake, she is at a risk of, very good Niveta, it is hepatic adenoma. She is at an increased risk of hepatic adenoma. So please remember, OCP intake can also cause FNH, that is focal nodular hyperplasia. Okay? OCP intake can also cause FNH, focal nodular hyperplasia. But the more commoner one would be hepatic adenoma, which is commonly associated with OCP intake. Okay, please remember this. If I talk about the vertebral hemangioma, it is the corduroy appearance of the polka dot sign. Yaad rakhna, important one-liners. It is the corduroy appearance of the polka dot sign. Don't forget it. Okay? No issues with this, anybody? I hope so. This was done. Now, please tell me what are the tumor markers for liver tumors. Okay, what are the tumor markers for liver tumors? Hepatic tumors के लिए tumor marker. jaldi se. What are the tumor markers for liver tumor? Very good. It is alpha fetoprotein. It is alpha fetoprotein. Then next one, it is HEPAR1. It is HEPAR1. एक ही याद मत करो. Alpha fetoprotein is not the best tumor marker. Please remember. Okay, it is alpha fetoprotein, HEPAR1. Also, neurotensin. Neurotensin is a tumor marker only for the fibrolamellar variety of HCC. याद रखना, neurotensin is a tumor marker only for the fibrolamellar variant of the HCC, and fibrolamellar variant of hepatocellular carcinoma has the best prognosis. Why to remember fibrolamellar variety of HCC? For two reasons. First, neurotensin will be the tumor marker, and second, it will have the best prognosis out of all. Okay? So overall, it would be alpha fetoprotein, HEPAR1, and the third one is known as arginase. So these are the three important tumor markers you need to remember for liver tumors. Please tell me the tumor marker for pancreatic cancer. Jaldi se. This is important. Tumor marker for pancreatic cancer we have discussed in pathology. Tumor marker for pancreatic cancer is known as pancreatic cancer is known as CA. Jaldi se. Tumor marker for pancreatic cancer is known as CA 19.9. Very good. Okay, please remember, tumor marker for pancreatic cancer is known as CA 19.9. Okay, tumor marker for pancreatic cancer is CA 19.9. No issues with this. Yaad rakho. And definitely the treatment of choice in cases of hepatic cancers, usually if it is a malignancy, definitely we need to do a liver transplant in this patient. Okay, and if it is only involving a specific lobe or only a specific segment, then a partial hepatectomy can also be done. A partial hepatectomy can also be done, and as we know, liver is able to regenerate itself. Next question says medicine में hepatobiliary छूट गया था, as I told you. So important things only I have done, only one side from medicine. So let me know the answer of this question, which was a recent recall. A patient having CLD, chronic liver disease. That means a patient was diagnosed with cirrhosis and presented to the OPD with fever, tachypnea, and gross abdominal distension. On abdominal examination, tenderness is elicited, and ascitic fluid reveals presence of 500 neutrophils per cubic millimeter. What is the next best step? First, let me know what is your provisional diagnosis. So definitely here a patient of cirrhosis comes to you, or a chronic liver disease patient comes to you with gross abdominal distension. Definitely you are going to think in terms of ascites. You are going to think in terms of ascites because the protein production from the liver will go down, and therefore there would be decreased plasma oncotic pressure, and that causes usually ascites in this patient. Okay? So ascites is usually seen. Very good, BA. It is spontaneous bacterial peritonitis. Why? Ascites is there in this patient, but along with ascites, they have also mentioned features of infection. They have also mentioned features of fever. There is tachypnea. Along with that, there is tenderness. Okay? And ascitic fluid tap usually reveals presence of 500 neutrophils per cubic millimeter. That means the ascitic fluid is usually infective in nature now. Okay? So please remember, they have actually given the diagnosis of spontaneous bacterial peritonitis. It is spontaneous bacterial peritonitis. Please remember. And here, what should be the next best step? The question was, what is the next best step? Akshay, you are right. If it was only ascites, definitely, as we have discussed, the drug of choice for ascites is always spironolactone. The drug of choice for any edema in cases of cirrhosis is usually spironolactone. Okay? And if it is a large volume ascites, as you can see in this condition, if it is a large volume ascites, definitely we need to do a large volume paracentesis. We need to do a large volume paracentesis. But here it is an infective condition. Definitely you need to start IV antibiotics. You need to start IV antibiotics in this patient, and that is what is a ceftriaxone. Which antibiotic you need to start? Ceftriaxone is usually started in this patient. Okay? Don't get confused. It is spontaneous bacterial peritonitis, a complication of ascites or cirrhosis in a patient. Okay? Normally ascites agar hota, drug of choice is usually spironolactone. And if it is a large volume large volume ascites, then definitely various signs can be elicited. Okay. First sign, usually a patient would be in this position, and then you will palpate the abdomen. That is what is called as the puddle sign. That is what is called as the puddle sign. And puddle sign is positive when the ascitic fluid volume is more than 100 ml. Okay. Ascitic fluid volume is more than 100 ml. At that time, the puddle sign would be positive. What is this sign? The next sign, important signs kara raha hu. Only I'm talking about the important aspects of liver over here. Jaldi. All image. This image came in August examination. I'm asking you about this. Okay, you will tap. Okay, you will percuss the patient from the midline towards the one side and towards the other side, and then you will ask the patient to change his or her position, and then you will again percuss the abdomen. Okay, but now this time the fluid would be almost towards the one side. Okay, and therefore the dullness would be shifted. So therefore, this one, the first image is what is called as the shifting dullness sign. The first one is called as the shifting dullness sign. The first one is called as the shifting dullness sign, and it is positive when the volume is minimum more than 500 ml. Shifting dullness is positive when the minimum volume of ascitic fluid is more than 500 ml. And the last one, all of you are right. The last one, it is called as the fluid thrill. Okay, the last one is known as the fluid thrill. So you ask the patient or any other person to keep a hand in between, and then you just tap. Okay, you just tap, or you just sorry. Okay, so you just tap from the one side and you keep the hand on the other side, and you can feel the fluid vibrations or the fluid thrill. Okay, so that is what is called as a fluid thrill. And fluid thrill is usually positive in cases of massive ascites. Fluid thrill is only positive in cases of massive ascites when the fluid volume is more than 1000 ml. Okay, when the fluid volume is more than 1000 ml. Yaad rakhna. No issues with this, anybody? Please remember this. If there is massive ascites, as I told you, the treatment of choice is definitely a large volume paracentesis. That means the fluid would be removed. Okay, large volume paracentesis. But before large volume paracentesis, to avoid, okay, so before large volume paracentesis, we need to give a substance, and that is called as, anybody? CHF में furosemide देंगे. Very good. CHF में we give furosemide in in cases of CHF, CLD, or in cases of cirrhosis we usually give spironolactone to the patient. ठीक है, ये हमने डिस्कस कर लिया था कार्डियो में. Treatment of choice, large volume paracentesis along with IV salt-free albumin. Please remember, IV salt-free albumin. IV salt-free albumin should be given in this patient. Please remember this. ठीक है. So this is important. The next one, this here you can see here what is the sign seen. This is what is your icterus. Okay, this is what is called as your icterus, and icterus is a sign of jaundice. Icterus is a sign of jaundice. Can anybody tell me? We have discussed this. What is the first site for icterus? Which is the first site for icterus? Very good. It is the frenulum of your tongue. Okay, it is the frenulum of your tongue followed by your sclera. Okay, and it is not the sclera first. Frenulum followed by your sclera. And as we have discussed about jaundice, there can be various causes of jaundice. It can be either a pre-hepatic jaundice, hepatic jaundice, or a post-hepatic jaundice, or obstructive jaundice. Okay, important. So in pre-hepatic jaundice, as I told you, I'll just revise it once again. Pre-hepatic jaundice is usually due to hemolytic anemia or any cause of hemolysis for that matter. And in pre-hepatic jaundice, there would be unconjugated hyperbilirubinemia. Unconjugated hyperbilirubinemia. If I talk about hepatic jaundice, okay, hepatic jaundice means there is some problem in the liver. It can be acute viral hepatitis for that matter. Here there would be elevated levels of conjugated as well as unconjugated bilirubin. Okay, there would be elevated levels of conjugated as well as unconjugated bilirubin. And lastly, if there is an obstructive jaundice, okay, there is some pathology in the biliary tract. It can be a stone or it can be a tumor like cholangiocarcinoma, anything. Okay, in that condition, definitely there would be increased levels of conjugated bilirubin. Okay, there would be conjugated hyperbilirubinemia. No issues with this. Now, please tell me if there is any biliary duct pathology, which enzyme is usually elevated? In cases of biliary duct or bile duct pathology, which if there is an obstructive jaundice or a post-hepatic jaundice, which enzyme would be elevated? Which liver enzyme is elevated? If definitely there is liver disease, the most specific enzyme to be elevated in liver disease is ALT. If any cases of liver disease, that means hepatic causes of jaundice, definitely the most important enzyme to be elevated is ALT, also known as SGPT, right? So it is ALT, alanine transaminase, where in cases of biliary pathology, please remember there would be elevated levels of ALP. If there is any cases of a biliary duct pathology, there would be elevated levels of ALP, that is alkaline phosphatase. There would be elevated levels of alkaline phosphatase. Yaad rakhna. Okay, no issues with this. Whereas if you talk about AST, okay, AST, if I talk about AST, please remember AST is usually elevated in cases of AST, or SGOT is elevated in cases of anybody. AST, aspartate transaminase. Aspartate transaminase is usually elevated in cases of alcoholic liver disease. Very good. It is elevated in cases of alcoholic liver disease. But the most specific test for alcoholic liver disease, anybody? The most specific test for alcoholic liver disease. ALT is elevated in all liver pathologies. AST is elevated in alcoholic liver disease, but it is not the most specific because AST can also be elevated in cardiac conditions. Therefore, very good. It is the AST by the ALT ratio, or SGOT by the SGPT ratio. SGOT by the SGPT ratio, and the ratio should be more than 2:1. Okay, the ratio should be more than 2:1. That is important. Okay, please remember this. No issues with this. Yaad rakh lena. This is important. Okay, SGOT by the SGPT ratio. No issues with this. More than 2:1 is suggestive of any alcoholic liver disease in the patient. Alcoholic liver disease में जल्दी से बता दो, micronodular cirrhosis or macronodular cirrhosis? Micro or macronodular cirrhosis? Okay. So usually in alcoholic liver disease, due to chronic alcoholism in the patient, the liver will start showing changes. There would be hepatitis in the patient. First of all, there would be fatty liver changes. Okay, there would be fatty liver changes, which is called as microvesicular or macrovesicular steatosis is seen. Then there would be alcoholic hepatitis, and the third stage would be cirrhosis. Very good at MK creation. It is micronodular cirrhosis. Less than 3 mm nodules are seen on the liver surface. Okay, in alcoholic liver disease, micronodular cirrhosis is usually seen in the patient. No issues with this. याद रख लो ये, ठीक है, important है. And the treatment of choice is definitely liver transplant in cases of cirrhosis. No issues with that. Okay, I feel so. One of the complication important, याद रखना, it is spontaneous bacterial peritonitis. The other complications of cirrhosis can be hepatopulmonary syndrome or hepatorenal syndrome. Okay, when the renal or kidney functions would be impaired, that is called as hepatorenal syndrome. And if the patient is having respiratory distress, there is pulmonary edema, then that is what is called as hepatopulmonary syndrome. Okay, these are the complications of cirrhosis in a patient. याद रखना, multi-organ dysfunction भी हो सकता है cirrhosis. Then if I talk about serology, important है, एक बारी बस cover कर रहा हूँ. as we had left, and I don't want you to miss out on this. Serology, if I talk about hepatitis B, acute viral hepatitis on ultrasound abdomen, we discussed it gives the starry sky appearance, right? So in cases of acute hepatitis, usually hepatitis A and hepatitis E are usually due to fecal-oral route of transmission. Okay, important. Where are all others are usually due to? All others are usually due to sexual route of transmission, blood, or maybe due to parenteral route of transmission. Very good. On biopsy, we will see councilman bodies. Okay, please remember on biopsy of acute viral hepatitis, we will see councilman bodies as we discussed. These are apoptotic bodies, pinkish eosinophilic apoptotic bodies. Okay, yaad rakhna. Now, please talking about the serology. Please remember all other hepatitis viruses are RNA viruses except hepatitis B, which is a DNA virus. Important auric line. Next, if I talk about first one, please tell me now, jaldi jaldi bataoge tum. If I talk about acute infectious hepatitis B, so HBS, what should be positive? Sab likh ke bhej do jaldi se. Acute infectious hepatitis B. So if there is hepatitis B, okay, the first antigen to be appear, okay, the first antigen to be to appear is the HBS antigen. The first antigen to appear is the HBS antigen, whereas the first antibody to appear is the anti-HBC antibody. The first antibody to appear is the anti-HBC antibody. Yaad rakhna. Important. Whereas the last antibody to appear is the anti-HBS antibody. The last antibody to appear is the anti-HBS antibody. If they ask you which is the epidemiological marker of hepatitis, the answer is HBS antigen. Okay. If they ask you which is the epidemiological marker of hepatitis B, then the answer is HBS antigen. Okay. Or it is also called as the Australian antigen. It is also called as the Australian antigen. Very good. So if it is hepatitis B, okay, hepatitis B hai, so definitely if the patient is having infection, HBS antigen should be positive. HBS antigen should be positive. Anti-HBC antibody would be present. Okay, anti-HBC antibody would be present. But as it is an acute condition, which anti-HBC antibody? IgM. All of you are right. It is the IgM antibody. Which antibody? IgM, because it is acute condition. As it is infectious, and as we know, the marker of infectivity in cases of hepatitis B is HBE antigen. The marker of infectivity or marker of viral replication, if they ask you, two important one-liners. Marker of infectivity or marker of viral replication, it is usually HBE antigen. That is your envelope antigen. Okay? So it should be positive in cases of infectious hepatitis. It should be positive in cases of infectious hepatitis. So अगर वो बोलते हैं क्या कि HBE antigen positive है, that means it is infective in nature or there is an ongoing viral replication at this point of time. Okay? And anti-H and anti-HBS antibody would be negative because anti-HBS antibody is suggestive of recovery. Anti-HBS antibody is either suggestive of recovery or vaccination. Okay? Chronic hepatitis B. So this is important. Jaldi se chronic. अगले आंसर करते रहो. Please keep on answering the other ones. Chronic hepatitis B. Jaldi se. So again, it is hepatitis B. That means the patient is having infection. So HBS antigen is again positive, and HBS antigen is positive. The change would be now anti-HBC antibody would be there, but as it is chronic in nature, therefore it will be a IgG antibody. Therefore, it would be a IgG antibody. HBE antigen would be positive or negative. Jaldi se batao. HBE would be positive or negative. They have given chronic hepatitis B. They have given chronic hepatitis B. So whether it would be positive or negative, it would be negative. Very good. Because they have not written chronic infectious hepatitis B. They have not written chronic infectious hepatitis B. If they would have written chronic infectious hepatitis B or chronic active hepatitis B, then I would have said yes, HB antigen would be positive, right? Please remember this. And anti-HBS antibody would be again negative because recovery is not there. In cases of recovery, please remember in cases of recovery, usually the anti-HBS antibody would be positive. Anti-HBS antibody would be positive. Anti-HB antigen would be negative. HBS antigen would be negative now. And anti-HBC antibody would be present and it is the IgG type. Okay. So IgG antibody along with anti-HBS antibody is suggestive of recovery. And which of the following serological marker would be positive in a vaccinated individual? Like you and me, we are vaccinated against hepatitis B. So which epidemiological which serological marker would be positive in us? As I told you already. Which serological marker is positive? Very good. It is the anti-HBS antibody. It is the anti-HBS antibody. Rest all would be negative. Rest all would be negative. Not anti-HBS and okay. Anti-HBS antigen antibody. Okay. Anti-HBS antibody is positive. No issues with this. Then I'll start with gallbladder. Okay. So liver ki important cheez at least I have discussed. Yaad rakhna itni to kam se kam. Then if I talk about gallbladder, guys, now, sorry, so gallbladder mein the most common thing that we come across is usually gallstones. Okay, gallstones also called as cholelithiasis. Okay, gallstones also called as cholelithiasis. Why gallstones are formed usually when there is a lithogenic bile. What do we mean by lithogenic bile? So please remember, lithogenic bile is a stone forming bile. Okay, so as all of us are quite aware, gallbladder ka function kya hota hai? It is to store the bile. What is the function of gallbladder? To store the bile, and second is to concentrate the bile. First is to store the bile, and second is to concentrate the bile. Okay, please remember. And when what happens if there is a highly concentrated bile or a super saturated bile? Okay, that is called as a lithogenic bile. That means there would be a higher risk or high probability of forming stones in that kind of bile. Okay, so usually if I talk about gallstones, these are usually of three types. Either it would be pigmented gallstones, cholesterol gallstones, or mixed gallstones. Please tell me which are the most common gallstones overall. Jaldi say, which are the most common gallstones overall? The most common gallstones overall are very good. Mixed gallstones. Most common gallstones overall are mixed gallstones. Most common gallstones overall are mixed gallstones. Whereas most common gallstones in Asia are most common gallstones in Asia. Most common, very good. Asia mein it is the pigmented gallstones. Most common gallstones in Asia. Oxalate are usually the renal stones. Yaad rakhna. We will discuss about them. Most common gallstones in Asia are pigmented gallstones. Most common in Asia are pigmented gallstones. Whereas if I say if there is a fat female, okay, if there is a fat female, okay, who is fertile, that means in a reproductive age group, and she is in her 40s. That means 4Fs. Okay, 4Fs. Fat female, fertile, and in her 40s. Then she would be at risk of producing cholesterol gallstones. Okay, then she would be at risk of developing cholesterol gallstones, which will contain more than 90% of cholesterol usually. Okay, so yaad rakhna, fat female, fertile, and in her 40s usually is at a risk of developing cholesterol gallstones. What is the investigation of choice for gallstones? Anybody? Jaldi say. What is the investigation of choice for gallstones? Investigation of choice for gallstones. Gallstones are not calcified. Please remember. So therefore, they cannot be seen on CECT. They are radiolucent. Therefore, the investigation of choice would be ultrasound abdomen. Please remember, the investigation of choice for gallstones is ultrasound abdomen. Investigation of choice for gallstones is ultrasound abdomen. Whereas investigation of choice for renal stones is a NCCT abdomen. Investigation of choice for renal stones is a NCCT abdomen. Yaad rakhna. ठीक है? On ultrasound abdomen in the gallbladder, you can see a gallstone. Okay, you can see a gallstone, and behind the gallstone there would be a posterior acoustic shadow. Behind the gallstone, what would be seen? There would be a posterior acoustic shadow. So why it is important? Please remember, it is important to differentiate gallstone from a gallbladder polyp. Okay, it is important to differentiate it from the gallbladder polyp. HIDA usually cholecystitis में करते हैं हम, not in cases of gallstones. ठीक है? So please remember, gallstones में usually the investigation of choice is the ultrasound abdomen, easy, cheaper one, okay, and easily accessible also. So the investigation of choice is ultrasound abdomen, and it will show a posterior acoustic shadow. Posterior acoustic shadow अगर दिख रही है, then definitely it is a gallstone. If posterior acoustic shadow is not seen, then it would be a gallbladder polyp. Then it would be a gallbladder polyp. This is how you differentiate. If I do a CECT, ठीक है, CECT कर सकते हो, but it is not the investigation of choice. If I do a CECT in cases of gallstones, what sign is seen? Here you can see which sign is seen. In cases of gallstones, very good. It is known as the Mercedes-Benz sign. Which sign is seen on CECT? Mercedes-Benz sign. Which sign is seen on CECT in gallstones? Mercedes-Benz sign. Which sign is seen in CECT of gallstones? It is the Mercedes-Benz sign. इस तरह की कुछ, ठीक है? Important. Then what is the treatment of gallstones? Anybody? Jaldi say. What is the treatment of gallstones? Seagull sign भी बोलते हैं उसको, seagull sign. Treatment of gallstones, guys. जल्दी से, अरे gallstones से निकाल दो ना. Treatment of choices. Usually see, it is usually in cases of definitive, yes, definitive management is laparoscopic cholecystectomy, guys, because if once gallstones are formed, there is a high risk that there would be recurrence, okay, and very common recurrence is usually seen. So if agar recurrence hota hai, then usually we prefer doing a definitive management, that is laparoscopic cholecystectomy. lap chole jisko bolenge, laparoscopic cholecystectomy. Surgery mein isliye pad rahe ho tum gallstones, right? If it would have been medical management, initial stages, if it is only the first episode, definitely we can manage with multiple drugs like ADCA, that is ursodeoxycholic acid vagera. Okay, but usually the definitive management is laparoscopic cholecystectomy in the patient, right? Important. Then if I talk about this condition, what is this? On a gallbladder, red gallbladder mucosa, you can see yellow flakes. Okay, Yes, if the stone is more than 3, okay, if the stone is usually more than 3 centimeters, yeah, if there are multiple gallstones in the gallbladder, okay, multiple gallstones in the gallbladder, there is recurrence, there is huge or a large gallbladder stone. In that condition, definitely we will prefer doing a laparoscopic cholecystectomy. अगर कुछ problem नहीं है patient को, then definitely we do not do anything. ठीक है, even we do not give any drugs to the patient if the patient is not having any symptoms. If the patient is having pain, then we can manage the patient with analgesics वगैरह, okay, and adka वगैरह can be given for dissolution of the gallstones. ठीक है, क्या is this a porcelain gallbladder? Yellow flakes on a red gallbladder mucosa. Characteristic appearance known as the strawberry gallbladder. Very good. It is the strawberry gallbladder. And strawberry gallbladder is seen in which condition? Strawberry gallbladder is a feature of. Strawberry gallbladder is a feature of. Strawberry gallbladder is a feature of cholesterosis of gallbladder. Strawberry gallbladder is a feature of cholesterosis of gallbladder. Strawberry gallbladder is a feature of cholesterosis of gallbladder. Please remember, this is important. Whereas what you are talking is this one. On a CECT, if you can see a calcified gallbladder wall. On CECT, if you can see a calcified gallbladder wall. This is what is called as the porcelain gallbladder. ये image आई थी August में. Okay, this is what is called as a porcelain gallbladder. This is what is called as the porcelain gallbladder. And please remember, porcelain gallbladder is highly suggestive of malignancy. Porcelain gallbladder is highly suggestive of malignancy. So if there is porcelain gallbladder, definitely you need to remove the gallbladder. That is laparoscopic cholecystectomy should be done if there is a porcelain gallbladder. BRB useful है, हाँ, patient को मत बताना बस. Then moving further, what is this triangle called as? So please remember, what is this triangle called as, anybody? So please remember, यहाँ पे है ना, ये image में तो बहुत गलत दिया हुआ है. So the larger triangle, okay, please remember the larger triangle is actually called as the cystohepatic triangle, okay. The larger triangle that we have, this starts from the inferior surface of the liver, okay, and goes over here. This is actually called as the cystohepatic triangle. It is called as a cystohepatic triangle. And in between that, a smaller triangle which is seen, यहाँ पे clearly नहीं दिख रहा, but a smaller triangle which is seen, that is what is called as a Calyx triangle, okay. That is what is called as a Calyx triangle, ठीक है. That is what is called as a Calyx triangle, ठीक है. Important है. Now most of the books say it as like, what are the borders of Calyx triangle? So please remember the borders of Calyx triangle. Medially it is the common hepatic duct. Medially it is the common hepatic duct. Medially it is the common hepatic duct, okay. Laterally it is the cystic duct. Laterally it is the cystic duct, okay. Laterally it is the cystic duct. Now important है, some books say the superior border is either formed by the inferior surface of liver, or some books say the superior border is formed by the cystic artery, okay. Superior border is formed by the cystic artery. Some books differ in this, okay. So you can remember that the borders usually are formed by the inferior surface of liver, like whatever is in your notes usually, ठीक है. So हाँ, मैं वही बोल रहा हूँ कि mostly they prefer calling this one, the bigger one, as a cystohepatic triangle. In between that, the smaller one is actually called as the Calyx triangle, ठीक है, याद रखना. So that is how they differ. And they say some books say Calyx triangle का content नहीं है cystic artery. Some books say it is there, okay. So please remember, usually you can remember it according to your notes itself, ठीक है. The inferior surface of liver is your superior border. Medial border is formed by the common hepatic duct, and the lateral border is formed by the cystic duct. And the content is called as the cystic artery. Content is usually the cystic artery, ठीक है. Important. No issues with this, I hope so. Then what is this? Here, this image also came in August examination. Gallbladder पे भर के questions August. What is this image? Here you can see a gallbladder, definitely, right? A gallbladder which is opened up. And what can be seen? There are no stones, okay. Stones तो नहीं है, इतना समझ में आ रहा है. Cholesterosis भी नहीं है, because no yellow flakes are seen usually, ठीक है. So polyps are usually sessile or pedunculated. Cyst पानी का है अंदर, okay. Polyps, very good, Jayashree. It is cancer. So please remember, this is gallbladder cancer usually, ठीक है, याद रखना. It is a gallbladder cancer. Polyp is usually a sessile, single or multiloculated भी अगर होंगे, so they would be either sessile or pedunculated. Here you can see the whole gallbladder is damaged, okay. The total architecture of the gallbladder is damaged. That is what is a gallbladder cancer. बस इतना ही पूछा था. A patient came to you, gallbladder removal was done, laparoscopic cholecystectomy, and then this image is given. What is this? So the diagnosis over here was gallbladder cancer. No issues with this, याद रखना. Gallbladder cancer, please remember, it has the worst prognosis out of all the cancers, okay. It has worst prognosis. Why? Because here the palliative treatment also does not work much in the patients, okay. That is why gallbladder cancer does not have a good survival outcome. and therefore it has the worst prognosis. It is more common in females though. Okay. Next, if I talk about this one, what is this? Anybody? Jaldi say. Now, if gallbladder stone agar hai, okay, if there is a polylithiasis, that is a gallbladder stone. Now, this gallbladder stone from the gallbladder, now it will slip into the duodenum. From this gallbladder, it will slip into the duodenum. It is usually due to formation of a fistula. It is usually due to formation of a fistula. Cholecystoduodenal fistula is formed. Cholecystoduodenal fistula, due to which the gallbladder stone will slip into the duodenum and it will go and obstruct the small intestine. It will go and obstruct the small intestine. So what is this condition called as? Jaldi. This condition is actually called as triad ka naam batao jaldi se. This condition is called as gallstone ileus. Very good, Niveta. The condition is called as gallstone ileus. The condition is called as gallstone ileus. Okay, important. There would be a dynamic obstruction. There would be a dynamic obstruction of the intestine. Very good, Rajneesh. The gallstone ileus mein the triad is known as regular triad. Okay, gallstone ileus mein the triad is known as the regular triad. Okay, the triad is known as the regular triad. And what are the three features of regular triad? First, pneumobilia. That means air inside the bile. Okay, here you can see there is air inside the bile. That is what is known as pneumobilia. Second, due to the gallstone in the intestine, there would be small bowel obstruction. And small bowel obstruction, as we say, on a CCT or on an X-ray, it is described as what? It is described as multiple air fluid levels. So it would be described as multiple air fluid levels, and multiple air fluid levels are suggestive of small bowel obstruction. Multiple air fluid levels are suggestive of small bowel obstruction. And the last one that you can see, there would be a presence of gallstone in the intestine. There would be presence of gallstone in the intestine. Okay, that is what is the regular triad. So jaldi say regular triad is remembered by first pneumobilia, second small bowel obstruction, and third it is gallstone. First is pneumobilia, second is small bowel obstruction, and third is gallstones in the intestine. Okay, no issues with this. That is usually your gallstone, I guess. Next, if I say, if this gallbladder stone at the neck, okay, gallbladder stone at the neck of the gallbladder will compress the common bile duct. Okay, if the gallbladder stone at the neck of the bile duct, neck of the gallbladder will compress the CBD. Okay, if gallbladder stone is at the neck of the gallbladder and it will compress the CBD, then this condition is called as, if it will compress the CBD, the patient will develop jaundice, and this condition is called as, anybody? Very good. It is known as the Mersey syndrome. It is known as the Mersey syndrome. If the gallbladder stone at the neck will compress the common bile duct, it is what is called as the Mersey syndrome. It is known as the Mersey syndrome. So important, alag-alag conditions se ye yaad rakhni hai tumhe. Next, if I say about this condition, guys, a patient presents to you with sudden onset right upper quadrant pain. Sudden onset right upper quadrant pain, or they can describe it as right hypochondrium pain. Okay, right hypochondriac pain. There is fever in the patient, nausea and vomiting. So fever, nausea and vomiting are suggestive of some infective or inflammatory condition, right? The sign given below is elicited, diagnosis and investigation of choice. So the sign over here, when you press, okay, when you usually press the right hypochondrium, there would be pain. This is what is known as your Murphy's sign. This is what is known as your Murphy's sign. Okay, and Murphy's sign is positive in cases of. Murphy's sign is positive in cases of. Very good. So here the diagnosis would be acute cholecystitis. Here the diagnosis would be acute cholecystitis. Here the diagnosis would be acute cholecystitis. So please remember, in acute cholecystitis, there can be history of gallstones in the patient, and that gallstone can come at the gallbladder neck, okay, at the level of Hartmann's pouch. Okay, it usually obstructed at the level of Hartmann's pouch, and that can cause inflammation of your gallbladder, and the patient can manifest like the patient can come to you with symptoms of sudden onset right hypochondriac pain or right upper quadrant pain, fever, nausea, vomiting. Okay, Murphy's sign would be positive, so the diagnosis would be acute cholecystitis. Then that would be known as calculus cholecystitis. Very good. And if stone is not there, okay, stone is not the cause, then it is called as acalculous cholecystitis. Okay, acalculous cholecystitis. It is due to different various other conditions. Acalculous cholecystitis can be seen. Okay. Now, sorry, what is the investigation of choice? Jaldi se, acute cholecystitis ke liye, what is the investigation of choice? Anybody? Very good. It is the ultrasound abdomen. Investigation of choice would be ultrasound abdomen. Investigation of choice is the ultrasound abdomen. Whereas if I talk about the gold standard investigation or the best investigation for acute cholecystitis, gold standard or the best investigation. Very good, Nivedita. It is HEDA scan. It is the HEDA scan. What do we mean by HEDA scan? hepatobiliary immunodiacetic acid scan. Okay, hepatobiliary immunodiacetic acid scan. That is what is known as a HEDA scan, which is a gold standard of the best investigation for acute cholecystitis. Whereas the normal investigation of choice is ultrasound abdomen. Okay, ultrasound abdomen is usually seen. Okay, no issues with this. Now, if a patient is having acute cholecystitis, what is the treatment? Anybody, jaldi. What is the treatment for acute cholecystitis? Treatment for acute cholecystitis. Jaldi say. Very good. Acute cholecystitis is treated conservatively. Acute cholecystitis is treated conservatively. Why? Because please remember, yes, conservatively, because please remember, now the patient is having inflammation. You cannot operate. Okay, you cannot operate the patient right now. Otherwise, if there is somewhat spillage also, that can cause peritonitis in the patient during operation. Therefore, in cases of acute cholecystitis, the treatment would be conservative. That means IV fluids would be given, IV antibiotics are usually given. Okay, so all of these things are given, IV antibiotics, IV fluids. Okay, so all of these things would be given, and after 6 weeks you will perform a laparoscopic cholecystectomy. After 6 weeks, okay, if you will perform a laparoscopic cholecystectomy. Okay, no issues with this. That is what is called as a lap chole. That is what is called as a laparoscopic cholecystectomy. Then on a CECT abdomen, CECT was performed, and this type of gallbladder is seen. That means there is presence of air. Black means air, right? So there is presence of air surrounding the gallbladder. This type of cholecystitis is called as, anybody, this type of cholecystitis when there is air surrounding the gallbladder. Air surrounding the gallbladder. Voice gone for you? Please let me know. ये क्या है? अच्छा, cholecystectomy. Voice is gone for everybody. Okay, then fine. ठीक है, जल्दी से बताओ. What is this called as? This is called as emphysematous cholecystitis. Please remember, this is called as emphysematous cholecystitis. जहां भी air होगा, that is called as emphysematous cholecystitis. Okay, so here usually when there is presence of air surrounding the gallbladder, this is called as emphysematous cholecystitis. Emphysematous cholecystitis, and the organism responsible for emphysematous cholecystitis is the one which produces gas, and the one which produces gas is usually Clostridium perfringens. Okay, the organism responsible is Clostridium perfringens. No issues with this. याद रखना, important चीज है. Next, if I talk about the next question, Clostridium vaccae was the previous name. Yes, a neonate has progressive jaundice at birth and pale stools. LFT shows raised ALP. Investigation of choice. तो सबसे पहले तो ये बताओ, a neonate presents to you with progressive jaundice at birth itself. Okay, and there is also presence of pale stools. LFT showing raised ALP. If there is elevated levels of ALP, alkaline phosphatase, it is suggestive of which kind of pathology? Pre-hepatic, hepatic, or post-hepatic? Jaldi batao. The pathology is in pre-hepatic channels, hepatic channels, or post-hepatic. That is the bile duct. कहाँ होता है? As I discussed, it is extra-hepatic or post-hepatic. Okay, so the pathology is extra-hepatic or post-hepatic. Pre-hepatic नहीं, it is extra-hepatic or post-hepatic. ठीक है? Pre-hepatic तुम जो अगर इसके terms में बोलोगे, portal hypertension. I am talking about usually jaundice. ठीक है? So here it is usually post-hepatic or extra-hepatic cause. Right? That means there is some pathology in the biliary duct. Okay, and if a neonate presents to you with progressive jaundice at birth itself, along with pale stools, okay, dark urine, all of that, and LFT showing raised ALP, the first line, the provisional diagnosis or the preliminary diagnosis that I will think of is usually biliary atresia. Okay, the diagnosis I will think in terms of is biliary atresia. And what is that investigation of choice for biliary atresia? Batao. So biliary atresia, by the name it is evident, that means the bile ducts or the biliary tree is not properly formed. Okay, that is what is called as biliary atresia. So here you can see type 1 biliary atresia, common bile duct is not formed. In CBD is not formed in type 1. CBD is not formed in type 1. CBD is not formed in type 1. CHD, that is your common hepatic duct, is not formed in type 2. Okay, CHD, that is your common hepatic duct, is not formed in type 2. Whereas right and left hepatic ducts are not formed in type 3. Right and left hepatic ducts are not formed in type 3. So jaldi say type 1 CBD, type 1 CBD, type 2 CHD, type 2 CHD, and type 3 right and left hepatic ducts. Type 3 right and left hepatic ducts. Okay, right and left hepatic ducts. No issues with this. Yaad rakhna. Investigation of choice would be So please remember, first line investigation is definitely ultrasound abdomen. First line investigation is ultrasound abdomen, but the investigation of choice or the best investigation that we have is usually a HIDA scan. Okay, the best investigation that we have is a HIDA scan. That is a HIDA scan, because on ultrasound we cannot visualize all the biliary pathway. Okay, and therefore it is inconclusive usually. Most of the times, ultrasound cannot give us a good idea about the biliary atresia. Then, if it is biliary atresia, what is the treatment option? So if it is type 1, please tell me, if it is type 1 biliary atresia, what is the treatment of choice? Type 1 biliary atresia. Type 2 or type 3 का सबको पता होगा. Type 2 and type 3, all of you might be knowing. Type 2 and type 3, it is Kasai's procedure, Kasai operation. Type 2 and type 3, it is the Kasai operation. Audible? Audible? ठीक है. Audible है ना? Please let me know if I can proceed. Yeah. So please remember, for type 2 and type 3, it is a Kasai operation or a Kasai procedure. Type 2 and type 3, it is a Kasai operation or a Kasai procedure. But for type 1, it is, jaldi se, for type 1, it is hepatico-jejunostomy. Very good. It is a hepatico-jejunostomy. For type 1, it is a hepatico-jejunostomy, because if also termed as ROX-NY hepatico-jejunostomy, also termed as ROX-NY hepatico-jejunostomy. पूरा नाम याद रख लो चाहिए तो, ठीक है, ROX-NY hepatico-jejunostomy. ठीक है. So if CBD is not formed, you can pull up the jejunum and just attach it to the right and left hepatic ducts. ठीक है. No issues with this. याद रखना. Important. So then if I talk about, so याद रखना, type 1 biliary atresia, hepatico-jejunostomy. Type 2 and 3 biliary atresia, Kasai operation or the Kasai procedure. Next, if I talk about, again, a child presenting to you with a abdominal mass. Okay, child presenting to you with a abdominal mass is there. Along with that, sometimes the patient can also have pain. Okay, along with that, there is jaundice in the child. So abdominal mass, pain and jaundice is which triad? Anybody? Abdominal pain, mass and jaundice is which triad? Abdominal pain, mass and jaundice. Jaldi se batao. Abdominal pain, mass and jaundice is which triad? It is not Charcot triad. Yaad rakhna. Usually, if I talk about the Charcot triad, it is usually seen in cases of cholangitis. Charcot triad is when the biliary duct, so the biliary pathways are inflamed. Okay. In cases of cholangitis, there would be Charcot triad. In cases of cholangitis, there would be Charcot triad. Okay. So Charcot triad is a feature of cholangitis when there is inflammation of the biliary pathway. And Charcot triad is pain, fever, and jaundice. Charcot triad is pain, fever, and jaundice. Please remember, Charcot triad is pain, fever, and jaundice. Important. And if I add two more things to it, okay, if I add hypotension, okay, if I add so Charcot triad ke saath, if I add hypotension and mental confusion, then it becomes which pentad? Then it becomes Charcot triad is pain, fever, jaundice. Charcot triad is pain, fever, jaundice. Charcot triad is pain, fever, jaundice. Whereas along with Charcot triad, if I add hypotension and confusion, it becomes the Raynaud's pentad. If I add Charcot triad ke saath hypotension, okay, if I add Charcot triad ke saath hypotension and confusion, it becomes the Raynaud's pentad. It becomes the Raynaud's pentad. No issues with this. Please remember this. Okay. So Charcot triad or Raynaud's pentad is a feature of cholangitis. Here I am asking you about another condition: abdominal mass, pain, and jaundice. This is known as the choledochal triad. All of you, very good. So this is known as the choledochal triad. This is known as the choledochal triad. Okay. So choledochal triad hota hai, yaad rakhna. Okay. Please remember this. So choledochal triad ki agar main baat karu, please remember, if there is a choledochal triad, definitely it is usually suggestive of a choledochal cyst. It is suggestive of a choledochal cyst. And what do we mean by choledochal cyst? That means there is a cystic dilatation in the biliary pathway. There is a cystic dilatation in the biliary pathway. Okay? So this is what a cystic dilatation looks like. Okay, so cystic dilatation in the biliary pathway. Okay, type 1, type 2, and type 3 are associated with the common bile duct. Type 1, type 2, and type 3 are associated with the CBD, common bile duct. Type 1, type 2, and type 3 are associated with the common bile duct. Type 1 is cystic dilatation of CBD. Type 2 is a diverticulum in CBD. And type 3 is usually dilatation in the duodenal part of CBD. Okay, type 3 is dilatation in the duodenal part of CBD. ठीक है, याद रखना. So type 1, type 2, and type 3 are associated with CBD, whereas type 4A is extra and intrahepatic. Type 4A is presence of extra as well as intrahepatic cyst. Type 4A is extra and intrahepatic cyst. Type 4B is extra hepatic cyst only. Type 4B is extra hepatic cyst only, whereas type 5 is multiple intrahepatic cyst. Type 5 is multiple intrahepatic cyst, and as we know, type 5 is also known as the Caroli's disease. Type 5 choledochal cyst is also known as Caroli's disease. So jaldi se, type 1, type 2, type 3 CBD. Type 1, type 2, type 3 CBD. Type 4A extra and intrahepatic. Type 4A extra and intrahepatic. Type 4B extrahepatic only. Type 4B extrahepatic only. Type 5 intrahepatic only. Type 5 intrahepatic only. And type 5 is also called as Caroli's disease. No issues with this. What is the treatment of choice? Jaldi se batao. What is the treatment of choice in cases of choledochal cyst? Jaldi se. What is the treatment of choice in cases of choledochal cyst? Treatment of choice in cases of choledochal cyst. Anybody? Very good. We will perform a ERCP along with sphincterotomy. We will perform a ERCP along with sphincterotomy. यहाँ पे जगह नहीं, मेरे पास थोड़ी सी कम है. So we will perform ERCP with sphincterotomy. Okay, we will perform ERCP with sphincterotomy. Okay, we will open up the sphincter properly and we will repair up the cyst. Okay, we will repair the cyst properly. Okay, so ERCP with sphincterotomy. So ERCP is a diagnostic as well as a therapeutic indication. ERCP has a diagnostic as well as a therapeutic indication. MRCP can be done, but it will only done for diagnosis. But ERCP is usually used for treatment as well. Okay. Next, if I move further, guys. Next, if I move further, here you can tell me what is this investigation called as? What is this investigation called as? Anybody? What is this investigation called as? Very good. This is a ERCP. This one is a ERCP. Please remember, this one is a ERCP. Okay. So if you can see this, okay, if you can see this pipe, okay, then that what is a ERCP. Okay. So endoscopic retrograde cholangiopancreatography, ERCP. Endoscopic retrograde cholangiopancreatography. Okay, ERCP. You can see this port, okay, of the ERCP port can be seen usually. Okay. And what is this? Anybody? What is this investigation? This investigation is usually done or this is also used as a treatment approach also. Very good. This is also used as a treatment approach when you repair the biliary duct or when you repair the biliary tract. Okay. After that, as you have applied sutures, okay, then you insert this T tube. You insert this T tube. Okay. So it is something like this. Okay. It is this T tube which is inserted in the bile duct for some days. Okay. That is what is a T tube. So here you can, here you have imaged the T tube. Therefore, it is called as a T tube cholangiogram. This one is called as a T tube cholangiogram. This one is known as the T tube cholangiogram. No issues with this. Yaad rakhna, this is a T tube cholangiogram. Okay, please remember this. I hope so. Everything is clear to everybody. Starting with urology now. If I talk about urology, important is upper and the lower urinary tract. So please tell me, if I talk about contrast studies in the urinary tract, if I talk about contrast studies in the urinary tract, please tell me which is the contrast study done for kidney. What is that contrast study done for kidney called as? When we inject the dye and then, yeah, what is this? Gopi, can you message in English so that we can also understand and we can also respond to it? Okay? So, jaldi se. Guys, for kidney, what is the contrast study known as? It is called as IVP. Okay, for kidney, the contrast study is known as IVP, intravenous pylography or intravenous urography, IVP or IVU. Okay, it is IVP or IVU for the kidneys, okay, or for the upper part of the ureter. So for kidney, renal, pelvis, and ureter, it is known as IVP or IVU. Okay, sorry. For urinary bladder, it is known as anybody. For urinary bladder, it is known as. So this pylography, please remember, urography, it can be either antegrade urography or a retrograde urography. Okay. For urinary bladder, please tell me. For urinary bladder, the contrast study is known as. For urinary bladder, the contrast study is known as. Arey, naam se hi hai na? For urinary bladder, it is known as the cystography. For urinary bladder, it is known as the cystography. Okay. Whereas for the urethra, it is known as RGU. For urethra, it is known as the RGU. That is retrograde urethrogram. For urethra, it is known as the RGU, retrograde urethrogram. Whereas, yes, MCU can also be done for bladder. Please remember, MCU is the investigation of choice for, please tell me, MCU is micturating cystourethrogram. What is MCU? Micturating cystourethrogram, also called as voiding urethrogram. That means you inject a dye into the urinary bladder and then you take serial x-rays of the patient when he is micturating, okay, or when he is urinating. तो बहुत ज़्यादा पानी पिला दो, dye ये कर दो, and then you will take the sorry. Okay, you will inject the dye into the urethra and then to the urinary bladder, and then when the patient urinates, you will take the picture. That is what is the MCU, micturating cystourethrogram or a voiding urethrogram. You're avoiding cystogram. That is done. The investigation of choice. MCU. Please remember, this is important one-liners. MCU is the investigation of choice for posterior urethral valve and vesico-ureteric reflux. MCU is the investigation of choice for posterior urethral valve and vesico-ureteric reflux. Posterior urethral valve and vesico-ureteric reflux. दोनों के लिए it is the MCU, which is the investigation of choice. No issues with this. Now starting with this. What is this? If I talk about renal anomalies or the kidney anomalies, okay. So one of the most common kidney anomalies is this one. When you can see there is a pair of ectopic kidneys, okay. Both the kidneys are not in its original position. So there is a pair of ectopic kidneys and both the lower poles of the kidneys are fused, okay. In both the kidneys, the lower poles are fused to each other, okay. So the lower poles are fused to each other. Lower poles are fused to each other. What is this type of condition called as? Very good. This is a horseshoe kidney. This is a horseshoe kidney. So what is the problem in horseshoe kidney? First of all, both the kidneys are ectopic. They are not that their original position. Second, both the lower poles are fused to each other. Kidney ke dono lower poles will be fused to each other. What is the most common site for horseshoe kidney? Anybody? Jaldi say. So the patient will present to you with the abdominal mass. A midline abdominal mass would be there, or abdominal swelling would be there, or a lump would be there. Okay. So the child would be having, okay, very good. The swelling or the lump would be at the L4 level. So L3, L4 hota hai. L3, L4 is the most common site. But if you need to answer one, single best answer would be L4. Single best answer would be L4. Single best answer would be L4 for the horseshoe kidneys. You do not treat the patient until and unless the patient is developing any symptoms. Until and unless the patient does not have any problem, you do not treat the patient or you do not do a resection in this patient. Okay? Yaad rakhna. Then what is this image? So this is definitely a CECT abdomen. This is usually a CECT abdomen. On the CT abdomen, you can see what? In the kidneys, you can see there are multiple fluids. Okay. So hypoechoic areas hota hai. That means fluid hoga usme. ठीक है? Air hoga ya fluid hoga. So here you can see there are multiple hypoechoic areas, hypodense areas rather, and that contains fluid. So this is definitely a polycystic kidney disease. This is definitely a polycystic kidney disease. There are multiple cysts in the kidneys, okay? And in polycystic kidney disease, not only the kidneys are involved, but other organs are also involved. Here you can see on the surface of the kidneys, there are multiple cystic dilatations or cysts on the surface of the kidneys. So in kidney, definitely in PCKD, the most common organ involved is definitely the kidneys, but the most common extra-renal site for cysts, anybody? Most common extra-renal site for cysts, jaldi se. Most common extra-renal site for cyst is? Most common extra-renal site for cyst is? Most common extra-renal site for cyst is? Liver. Very good. Most common extra-renal site for cyst is liver. Most common extra-renal site for cyst is liver. Now PCKD, as we know, PCKD can be of two types. Either it can be a infantile PCKD, either it can be a infantile PCKD, which is rare usually. Either it is an infantile PCKD, which is usually rare, or the other one is a dominant PCKD, or other one is a adult PCKD. Other one it is a adult PCKD or a congenital PCKD. So adult PCKD is also called as congenital PCKD. Adult PCKD is also called as congenital PCKD, and it is more common. So if they ask you which is the more common type of PCKD, then the answer would be adult or congenital PCKD. The most common type of PCKD is adult or congenital PCKD. Here the patient presents to you after 25 years of age, usually after 25, 30 years of age. Okay, please remember. Now please tell me. The pattern of inheritance of infantile PCKD is. Pattern of inheritance of infantile PCKD is. Jaldi say. Pattern of inheritance of infantile PCKD is. Infantile, as you know, for infantile PCKD it is autosomal recessive. For infantile PCKD it is autosomal recessive. But for adult or congenital PCKD it is autosomal dominant. For adult or congenital PCKD it is autosomal dominant. Okay? No issues with this. And definitely there would be gene mutations in the PCKD1 or PCKD2 genes, that is polycystin 1 and polycystin 2 genes, which are located on chromosome number 16 and chromosome number 4 respectively. So PCKD1 on chromosome number 16 and PCKD2 on chromosome number 2. Okay, so chromosome number 4. Please remember this. Okay. What is the definitive management? Definitely the definitive management for this condition is liver transplant. The definitive management for this condition is liver transplant. Okay. So if they ask you what is the definitive management, the answer is liver transplant. But initial stages में we can perform de-roofing of cyst. Okay, in initial stages we can perform de-roofing of cyst. And the most common cause of death, anybody? Most common cause of death. Most common cause of death is due to hypertension related complication. Most common cause of death is due to hypertension related complications. याद रखना. No issues with this. Please remember this now. Next, what is this sign called as? Here you can see. Here the renal pelvis appears to be normal, but here the renal pelvis does not appear to be normal. What is this sign called as, anybody? Very good, very good. So here it is called as the drooping lily sign. कौन सी sign है ये? This is the drooping lily sign. Which sign is there? Drooping lily sign. And when is drooping lily sign seen? So please remember, drooping lily sign is a feature of drooping lily sign. Please remember, drooping lily sign is seen when there is double ureter or double renal pelvis. Okay, so that means there is duplication of renal pelvis and ureter. So in cases of duplication of renal pelvis and ureter, there would be drooping lily sign. So in duplication of renal pelvis and ureter, which sign is seen? Drooping lily sign. In duplication of renal pelvis and ureter, which sign is seen? Drooping lily sign. Okay, it is the drooping lily sign. So the upper pelvis, renal pelvis compresses the lower renal pelvis, and therefore it appears like a drooping lily sign. It appears like a drooping lily sign. So here now, if there would be double ureters, these double ureters more commonly they combine and open as a single ureter in the urinary bladder. But sometimes they can also open at other sites, and therefore it is known as the ectopic ureter. Therefore it is known as the ectopic ureter. Okay, and if there is an ectopic ureter, definitely the treatment would be reimplantation. If there is an ectopic ureter, the treatment would be reimplantation into the urinary bladder. But please tell me, what is the most common site for ectopic ureter in males and females? Most common site for ectopic ureter in males and females. Jaldi. Most common site for ectopic ureter in males and females. Most common site for ectopic ureter in males, it is usually the prostatic urethra. And most common site for ectopic ureter in males, it is the prostatic urethra, and therefore the patient would be at a higher risk of urinary tract infection. The male patient would be at a higher risk of urinary tract infection. But in females, it is distal to the distal sphincter. In females, it is distal to the distal sphincter. And as it is out of the distal sphincter, therefore there is no control. Okay, and therefore the urine is constantly dribbling out. So this is what is called as continuous dribbling of urine. Okay, there would be a continuous dribbling of urine in females. Yaad rakhna, in cases of ectopic ureters. So usually they are fond of asking you like ectopic wale questions. Okay, they will ask you about ectopic testes, they will ask you about ectopic ureters. Okay, so this is important. Next, if I talk about this, here we are performing IVP. So the investigation over here, the last one was also IVP. Here also it is a IVP, and the first one that you saw, this was a CECT. Okay, this one was a CECT. The other one was also a CECT. So IVP, intravenous pyelography. What is seen? कहाँ यूरेथ्रोसील दिख रहा है भाई रजनीश? This is the urinary bladder जिसमें है वो, ठीक है, urinary bladder में है वो dye. This is the problem. What is seen? Here you can see this renal pelvis is so smaller, okay, but here the renal pelvis and ureter are dilated. Here the renal pelvis and ureter are dilated. This is what is a case of hydronephrosis. So this is a easy condition, but most of us tends to miss it out. Please remember, here it is a case of hydronephrosis. When there is dilatation of the renal pelvis and ureter, that is what is called as a hydronephrosis. That is what is called as a hydronephrosis. So causes of hydronephrosis can be multiple. Causes of hydronephrosis can be multiple. Please remember, it can be due to vesico-ureteric reflux. It can be due to some obstruction like a ureterocele. Okay, so any of these causes can lead to a hydronephrosis. So if there is a dilated, bada aisa mota mota agar dikh raha hai renal pelvis and ureter, that is what is a hydronephrosis. No issues with this. Please remember, it is thin. Okay. Normally it is thin, but agar mota hai, then it is hydronephrosis. Then here what you can see, there is air again in the kidneys, and again air jahan jahan hota hai, usko kya bolenge hum? Emphysema. So therefore it is a emphysematous pyelonephritis. It is a case of emphysematous pyelonephritis. Pyelo means renal pelvis, nephra means kidney, it is means inflammation. So it is the inflammation of your renal pelvis and the kidneys. Okay, so here you can see it is the CCT abdomen. On CCT abdomen you can see air inside the kidneys. That is what is a emphysematous pyelonephritis. Okay, that is what is a emphysematous pyelonephritis. And what is the emphysematous pyelonephritis? Where the most common organism responsible is, हर जगह गैस वाला वही नहीं होता है. So please remember, this is important. हर जगह गैस वाला organism वही नहीं होगा. That is the reason I am telling it to you. Which is the most common organism responsible for emphysematous pyelonephritis? Most common organism responsible for emphysematous pyelonephritis, anybody? It is E. coli. Most common organism responsible for emphysematous pyelonephritis is E. coli. Most common organism responsible for emphysematous pyelonephritis is E. coli. Please remember this. ठीक है? So IVP पे क्या दिखेगा किसमें? Next, if I talk about this condition, what would be seen over here? What is seen? Here you can see a J-shaped ureter. Here you can see a J-shaped ureter. किस टाइप का ureter दिख रहा है? You can see a J-shaped ureter. कहाँ कोबरा हेड दिख रहा है? मैं कोबरा हेड बताता हूँ कैसे दिखता है. This is a J-shaped ureter, and J-shaped ureter is seen in which condition? J-shaped ureter or fish hook ureter. J-shaped ureter or a fish hook ureter. It is seen in cases of J-shaped ureter or fish hook ureter is usually seen in cases of BPH, benign prostatic hyperplasia. It is usually seen in cases of benign prostatic hyperplasia. It is usually seen in cases of benign prostatic hyperplasia. ठीक है, no issues with this. Please remember. So J-shaped ureter or fish hook ureter is usually a case of BPH, benign prostatic hyperplasia. No issues with this. Now, अब आया तुम्हारा ये अगस्त का भी क्वेश्चन था. This is a IVP. On this IVP, the renal pelvis and the ureter appears to be normal. थोड़ा बहुत dilatation है. Okay, on this side. Along with that, in this you can see bilaterally there is a condition, okay, which is more common in females. Okay, here there is the narrowing of the ureteric orifice, and if there is narrowing of the ureteric orifice, the intramural part of the ureters would be dilated, and the intramural part of the ureters would be dilated. This is what is leads to appearance known as the cobra head or the adder head appearance. Which appearance is seen? Cobra head or the adder head appearance. Which appearance is seen? Cobra head or the adder head appearance. And cobra head or adder head appearance is a feature of ureterocele. Cobra head or adder head appearance is a feature of ureterocele. Cobra head or adder head is the appearance of ureterocele. Please remember this. Okay, and ureterocele is usually a bilateral condition, more common in females. Okay, so it is due to narrowing of the ureteric orifice. Therefore, there is dilatation of the. Now, is it fine, everybody? Okay, thank you so much. So let's start. So please remember, IVP in PCKD we will get the spider leg appearance. No issues with this. Anybody now? Okay. Now moving further. Okay. Over here, what can be seen? Anybody? What can be seen over here? What can be seen? What is this appearance? This is usually renal TB. And what is the earliest feature of renal TB on IVP? So this is the IVP. And what is the earliest feature of renal TB on IVP? What is the earliest feature of renal tuberculosis in IVP? Earliest feature of renal tuberculosis and IVP. Flower vase appearance is usually seen in cases of horseshoe kidneys. ठीक है, so flower vase appearance on IVP. अगर मैं IVP की बात करूं, जल्दी से एक बार रिवाइज करवा देता हूं. Flower vase appearance or hand joining sign. Okay, flower vase appearance or hand joining sign. So just we'll revise it once. ठीक है, all IVP feature जल्दी से. So flower vase appearance on IVP, horseshoe kidney. Flower vase appearance on IVP, horseshoe kidney. Hand joining sign on IVP, horseshoe kidney. Hand join signing on IVP, horseshoe kidney. So horseshoe kidney में IVP कौन से दो sign दिखते हैं? Flower vase appearance, and second is the hand joining sign. Then PCKD on IVP, spider leg appearance. PCKD on IVP, spider leg appearance. ठीक है, no issues with this. Then drooping lily sign on IVP, duplication of renal pelvis and ureter. Drooping lily sign on IVP, duplication of renal pelvis and ureter. So duplication of renal pelvis and ureter में कौन सा sign दिखता है IVP पे? Drooping lily sign. It is the drooping lily sign. ठीक है, important. J-shaped or a fish hook ureter. It is usually seen in cases of benign prostatic hyperplasia, BPH. Okay, and cobra head or adder head appearance on IVP is seen in cases of ureterocele. Cobra head or adder head appearance is a feature of ureterocele. अभी कोई दिक्कत नहीं है? Yes, very good. It is the moth-eaten appearance. Okay, here you can see the most common site is affected in cases of renal TB is usually the renal chelicus. Okay, it is the renal chelicus. And the earliest feature that is seen is usually moth-eaten chelicus. The earliest feature which is seen is a moth-eaten chelicus. The earliest feature which is seen is a moth-eaten chelicus on IVP. Okay. So papillary necrosis would be there, that will further progress to moth-eaten chelicus. And lastly, this feature would be seen. Okay. In later stages, in cases of renal tuberculosis, this feature is okay. So in the last stages of renal tuberculosis, usually it will further progress to putty kidney or cement kidney. It will further progress to putty kidney or cement kidney. No issues with this. याद रख लो, ठीक है? I hope so. Now it is clear to everybody. And what is the treatment of choice? Definitely the treatment of choice would be ATT. That is your anti-tubercular therapy. It is the ATT or anti-tubercular therapy. No issues with this now, anybody? So याद रखना, in cases of renal TB, earliest sign on IVP is usually moth-eaten chelicus. whereas the late sign is putty kidney, which will further progress to cement kidney due to calcification, and the treatment of choice is ATT. Okay, treatment of choice is ATT. No issues with this. Now, what is this? This is a NCCT abdomen. This is a NCCT abdomen. And what is this on NCCT abdomen? In the kidneys, you can see there is a calcified structure. That is what is a renal stone. Okay, this is a calcified structure, what is called as a renal stone. So therefore, the investigation of choice for renal stones is anybody? Investigation of choice for renal stones. Jaldi say. Investigation of choice for renal stones are NCCT abdomen. Investigation of choice for renal stones is NCCT abdomen or NCCT KUB, whatever you write it. Okay. The investigation of choice is NCCT KUB for renal stones. Okay. Kidney, urethra, bladder. KUB ka full form. Okay. So now if I talk about the multiple other renal stones, which is the most common type of renal stone, please tell me. The most common renal stones are. We have discussed all this in nephrology, so I'll be a bit fast over here. Which are the most common type of renal stones? Very good. Calcium oxalate stones. Most common type of renal stones are calcium oxalate stones, right? Calcium oxalate stones can be either having monohydrate crystals or dihydrate crystals. Okay, they can be having monohydrate crystals or dihydrate crystals. Okay, so please remember, dumbbell shaped crystals are seen in which type of calcium oxalate stones? Dumbbell shaped crystals are seen in which type? Very good. Monohydrate. Okay, dumbbell shaped crystals are seen in monohydrate calcium oxalate stones. Okay, dumbbell shaped crystals are seen in monohydrate calcium oxalate stones. So in monohydrate calcium oxalate stones, which shape of crystals? Dumbbell shape of crystals. Then envelope shape of crystals in dihydrate calcium oxalate stones. The envelope shape of crystals in dihydrate calcium oxalate stones. Okay, so in dihydrate calcium oxalate stones, we will have envelope shaped crystals. We will have envelope shaped crystals. Then hexagonal crystals in, jaldi se, hexagonal crystals in the hardest renal stones. Hexagonal, very good. Hexagonal crystals are seen in the cystine stones. Hexagonal crystals are seen in the cystine stones. Hexagonal crystals are seen in the cystine stones, and cystine stones are the hardest renal stones. Cystine stones are the hardest renal stones. Whereas coffin lid crystals are seen in, coffin lid crystals are seen in, jaldi se, coffin lid crystals are seen in. Very good. Struvite stones or triple phosphate stones. Coffin lid crystals are seen in struvite stones or triple phosphate stones. Struvite stones or triple phosphate stones में which type of crystals? Coffin lid crystals. And lastly, irregular shaped crystals are seen in. Irregular shaped crystals are seen in. Irregularly shaped crystals are seen in. Uric acid stones. Very good. Irregular shaped crystals are seen in uric acid stones. Irregularly shaped crystals are seen in uric acid stones. Very good. Out of all the renal stones, which renal stones are radiolucent, means which would not be visible on a NCCT KUB or NCCT abdomen. Very good. Uric acid crystals are radiolucent. Uric acid crystals are radiolucent. The other radiolucent kidney stones, anybody? Apart from uric acid stones, the other type of kidney stones which are radiolucent. As I gave you the mnemonic. Very good. PG Lux is the mnemonic for radiolucent stones. Okay, PG Lux is the mnemonic for radiolucent stones. Radiolucent are the ones which cannot be seen on a X-ray or a NCCT. Okay, so P goes for the parotid duct stones. P goes for the parotid duct stones. P goes for the parotid duct stones. G goes for the gall stones. G goes for the gall stones. L goes for the lysine stones. L goes for the lysine stones. U goes for the urate or uric acid stones. U goes for the urate or uric acid stones. And X goes for the xanthine stones. X goes for the xanthine stones. So please remember which two renal stones are radiolucent. It is the urate or uric acid stones, and second is the xanthine stone. Second is the xanthine stones. Okay, no issues with this, anybody? Now please tell me, if a stone takes the shape of the pelvic calyceal system, then this type of a stone is called as, if a stone becomes very large in size and it takes the shape of a pelvic calyceal system, then it is called as which stone? Then it is called as a calculi. Which calculi? Very good. It is known as a staghorn calculi. Then it would be called as a staghorn calculi. Then it is called as a staghorn calculi. And staghorn calculi are which type of stones? Out of all these stones, staghorn calculi are formed from which type of stones? Staghorn calculi are formed from which type of stones? Jaldi. Staghorn calculi are triple phosphate stones. Very good. Staghorn calculi are triple phosphate stones. Very good. Triple phosphate stones are formed in which pH? Triple phosphate stones are formed in which pH? Acidic or alkaline? Very good. Aisha, it is alkaline pH. Okay, triple phosphate stones are formed in alkaline pH. Okay, triple phosphate stones are formed in alkaline pH, and therefore which infection is responsible for triple phosphate stones? Which infection? Very good, Shazad. There is Proteus infection. The infection responsible for causing triple phosphate stones is Proteus infection. Which renal stones are pH insensitive or pH independent? Which renal stones are pH insensitive or pH independent? They can form in any pH: acidic, alkaline, neutral, any pH. Which renal stones are pH insensitive. Very good, Rajnish. It is calcium oxalate stones. So calcium oxalate stones are pH insensitive. Okay, calcium oxalate stones are calcium pH insensitive. No issues with this, anybody? Shabash. Now, talking about renal stones, definitely if there is renal stone, the patient will have lumbar pain or loin pain, what we call it. Okay? So now, depending on the location of the stone, there would be pain in the patient. Okay, depending on the location of the stone, there would be pain in the patient. So if it is a kidney stone or an upper or mid ureteric stone, the pain would be in the lumbar region. Okay, so there would be a lumbar pain. Okay, please remember there would be a lumbar pain. Just a minute. There would be a lumbar pain. So if it is a kidney stone, the pain would be in the loin or the lumbar pain. So pain is in kidney, the pain is in the loin or the lumbar region. Okay? So in kidney stone, there would be lumbar pain. In kidney stone, there would be lumbar pain. If it is the upper 1/3 ureteric stone, if it is a stone in the upper 1/3 part of the ureter, okay, upper 1/3 mein, very good. It is a lumbar pain which is radiating to the testis or perineum. Okay, so lumbar pain radiating to the testis in males or perineum in females. Testis in males or perineum in females. No issues with this. Please remember. So if they give in a question that the patient is having lumbar pain radiating to the testis in males or perineum in females, then the location of the stone would be upper 1/3 of the ureter. Okay, the location of the stone would be upper 1/3 of the ureter. Next, if the stone is at the pelvic brim, this question has been asked. If the stone is at the pelvic brim, then the pain would be very good. It would be a lumbar pain which is radiating to the inner thigh. It would be a lumbar pain radiating to the inner thigh. Shabash. Pelvic brim pe agar stone hai, then it is a lumbar pain radiating to the inner thigh. If it is a urinary bladder stone, then there would be a if it is a urinary bladder stone, then there would be a suprapubic pain. If it is a urinary bladder stone, there would be a suprapubic pain. Whereas if it is a bladder neck stone or urethral stone, if the stone is at the bladder neck or it is at the ureter, then there would be a suprapubic pain which radiates to the tip of the penis. Okay, it would be a suprapubic pain radiating to the tip of the penis. Please remember, if the stone is at the bladder neck or in the urethra, okay, then it is the patient will experience a suprapubic pain radiating to the tip of penis. Jaldi se. Lumbar pain, kidney stone. Lumbar pain radiating to testis or perineum, upper 1/3 ureteric stone. Lumbar pain radiating to inner thigh, pelvic brim stone. Suprapubic pain, urinary bladder stone. Suprapubic pain radiating to the tip of the penis. Next, stone at the urinary bladder neck or stone at the urethra. Okay, take no issues with this. Now, if I talk about female, may usually it is at the labia. Okay, female may usually it would be at the clit or at the labia. Okay. Then, if I talk about the treatment, if I talk about the treatment now, jaldi se, depending on the stone location, you will treat the renal stone. Okay. Just like gallstones also. So kidney, ureter, kidney or upper or middle ureteric stone would be treated by kidney, or upper and middle ureteric stone is treated by, very good, Rajnish, it is ESWL. Okay, kidney, upper or mid ureteric stone is treated by ESWL. But ESWL is what? Extracorporeal shock wave lithotripsy. Extracorporeal shock wave lithotripsy. Okay, so here you will, okay, this image yaad rakh lo, there would be sound waves which would be sent on the stone. Okay, and due to the sound waves, okay, high frequency sound waves, the stone will break. Okay, the stone will break into pieces. Okay, and that is what is the ESWL. Okay, shock waves are sent to the stone, and due to the shock waves, usually the stone will break. Okay, so yaad rakhna. And then if the stone breaks, ye question aa chuka hai, ye image aa chuki hai. A patient underwent ESWL. Okay, a patient underwent ESWL, and after the stone was broken into multiple fragments, it lined up in the ureter. If the stone is lined up in the ureter, then it is called as which phenomena? If the stone fragments are lined up in the ureter, it is called as which phenomena? Jaldi se. Here you can see the red arrow are marking towards the fragments of the stone which are lined up in the ureter. Then it is called as the, jaldi se yaar, Strain-Strasse phenomena. This is what is called as the Strain-Strasse phenomena. Phenomena. Important image hai, yaad rakh lo. After ESWL, when the fragments of stone will line up in the ureter for excretion, that is what is called as the Strain-Strasse phenomena. And as Shazad, you have rightly mentioned, ESWL is only done if the stone is less than 2 centimeter. It is only done if the stone is less than 2 centimeter. If the stone is more than 2 centimeter, we will do a procedure known as, if the stone is more than 2 centimeter, we will do a procedure known as PCNL, that is percutaneous nephrolithotomy. We will do if the stone is more than 2 centimeter, we will do a procedure known as PCNL, that is percutaneous nephrolithotomy. Okay, percutaneous So if it is a low ureteric stone, please remember, if it is a low ureteric stone, it would be removed by ureteroscope. So there should be a ureteroscopic removal with a Dormia basket. If it is a low ureteric stone, it should be removed by a ureteroscope. So ureteroscopic removal by Dormia basket. If it is a urinary bladder stone, it would be removed by, please tell me, if it is a urinary bladder stone, it is removed by, jaldi say. If it is a urinary bladder stone, it is removed by urinary bladder. तोड़ के कैसे निकालोगे? तोड़ के, वही तो पूछ रहा हूँ. So urinary bladder stone is removed by, if it is a small stone, very good, it is removed by Lithula paxi. Okay, Jayashri, very good. If it is a small urinary bladder stone, it is removed by Lithula paxi. But if it is Lithula paxi, okay. But if it is a large urinary bladder stone, then it is removed by cystolithotomy. If it is a large urinary bladder stone, now lithotomy ही करेंगे, but it is not called as PCN, it is called as cystolithotomy. Okay, if it is a large or a giant urinary bladder stone, it is removed by cystolithotomy. What is the treatment of choice for urethral stone? If the stone is obstructed at the urethra, okay, what is the treatment of choice for urethral stone? Please let me know. Urethral stone के लिए क्या क्या करोगे जल्दी? Treatment of choice for, very good. You should push the stone back into the urinary bladder and treat it like a bladder stone. You should push the stone back into the urinary bladder and treat it like a bladder stone. Very good, all of you. Very good, very good. Now, please let me know what is the most common congenital anomaly of male urethra. What is the most common congenital anomaly of male urethra? Urethra to pata hai na? In males, it is usually 16 to 20 centimeters. In females, it is almost 3 to 4 centimeters in length. Diameter of a male urethra is 6 to 8 mm, whereas for female urethra, it is 4 to 6 mm. ठीक है, male urethra, very good, it is hypospadias. Most common congenital anomaly of male urethra is hypospadias. Very good. The opening of the urethra would not be at the tip, it would be on the ventral side. Okay, the opening of the urethra would not be at the tip, it would be on the ventral side. And if the opening of the urethra is on the upper side or the dorsal side, it is called as, if opening of the urethra is on the upper side or the dorsal side, then it is called as हाइपो, मतलब नीचे ओपनिंग होगी. ओके, वेंट्रल साइड पे. Epispadias. Okay, please remember, if the opening is on the dorsal side or the upper side, it is called as epispadias. ठीक है, it is called as epispadias. ठीक है, now it is visible, I feel so. We can start. So let's write it down jaldi se. If it is a kidney or upper or middle ureteric stone, okay, if it is a kidney, upper or middle ureteric stone, less than 2 centimeter, ESWL, less than 2 centimeter, ESWL, more than 2 centimeter, PCNL, more than 2 centimeter, PCNL. Low ureteric stone के लिए क्या था जल्दी से? Low ureteric stone is removed by low ureteric stone, ureteroscopic removal. And what is used for removal? We usually use a Dormia basket. ठीक है. Yes, if the stone is less than 6 mm, then it would not cause any problem. If the patient is asymptomatic, तो क्यों ही treat करोगे तुम, right? So usually, okay, if the patient is not having any problems, then if it is less than 6 mm stone, then definitely no treatment is given. Okay, it will come out by itself. Okay, low ureteric stone, ureteroscopic removal with Dormia basket. Urinary bladder stone अगर small है तो Lithula paxi, small है तो Lithula paxi. But if it is a large or a giant urinary bladder stone, then we will perform a cystolithotomy. Important. Open up the urinary bladder and remove the stone. That is what is cystolithotomy. Okay, large urinary bladder stone ki rate is the cystolithotomy. Okay, large urinary bladder stone ki rate is the cystolithotomy. Okay, important. And for urethral stone, as we discussed, for urethral stone it is push the stone back into the, okay, push the stone back into the urinary bladder. Push the stone back into the urinary bladder and treat it like a bladder stone. Treat it like a bladder stone. ठीक है? No issues with this. What is this? This image came earlier. ये image आई थी, ये X-ray आया था. What is this? You can see a giant calcified structure. Okay, and the options were usually the people were confused between. Okay, people were usually confused either between a calcified fibroid or a urinary bladder stone. So please remember how to differentiate. First of all, it is in the midline, lying in the pelvic cavity, and second, it is a homogeneously calcified structure. So it is usually a giant urinary bladder stone. Okay, and there was no history of fibroids as well, which was consistent with fibroids. So this is a giant urinary bladder stone, and it would be treated with cystolithotomy. It would be treated with cystolithotomy. No issues with this. Please remember this. Okay, important cheez hai ye. Next, if I talk about a patient presents with abdominal mass, flank pain, and hematuria. What is the diagnosis? A patient presents with abdominal mass, flank pain, and hematuria. This triad is seen in which condition? Patient presenting with abdominal mass, flank pain, and hematuria. So abdominal mass, flank pain, and hematuria. What is the diagnosis usually? So here the provisional, I'm not asking definitely, it is the fixed diagnosis, but yes, the provisional diagnosis would be RCC, that is your renal cell carcinoma. So abdominal mass, flank pain, and hematuria is a triad for renal cell carcinoma. Abdominal mass, flank pain, and hematuria. Renal cell carcinoma, it is the malignancy or cancer of the kidneys. Okay, so which is the most common type of renal cell carcinoma, whether it is squamous cell or adenocarcinoma? Renal cell carcinoma is which type? Squamous cell or adenocarcinoma? Jaldi se. Renal cell carcinoma is squamous or adeno? RCC is squamous or adeno? So definitely it is the adenocarcinoma. Definitely it is the adenocarcinoma, which is the most common site for renal cell cancer. The most common site for renal cell cancer. Jaldi se. Most common site for renal cell cancer. Which part of the nephron would be affected most commonly? The most common site for renal cell cancer is PCD epithelium. Most common site for renal cell cancer is PCD epithelium. Most common site for renal cell cancer is PCT epithelium. No issues with this. Please remember this. Then if I talk about the investigation of choice. Okay. If I talk about the investigation of choice, what is the investigation of choice for renal cell carcinoma? For all the cancers, it is biopsy. Is it so for renal cell cancer as well? Is it so for renal cell cancer as well? No, very good. For hepatic cancers, for usually liver cancers, or for your renal cancers, usually the patient, painless hematuria is seen in renal cell carcinoma. Please remember, painless hematuria is seen with renal cell carcinoma, but usually in the earlier stages. Okay? In the later stages, usually the patient can have pain. Okay? No issues with this. Next, if I talk, so here the investigation of choice is the CECT abdomen. Investigation of choice is the CECT abdomen. On this investigation of choice, that is CECT abdomen, you can see a giant mass in the kidney. Okay, you can see a giant mass in the kidney. So please remember why CECT abdomen is avoided in cases of liver cancer or in cases of kidney cancer. Because when you will perform biopsy or FNSE, what can happen? When you will remove the needle, there would be spread of this malignant cells into all the layers of the skin and or into the peritoneum as well. And therefore, to avoid that, the investigation of choice for renal cancer or liver cancer is usually a CECT abdomen. Which is the most common subtype of renal cancer? Anybody? The most common subtype of renal cancer is? The most common subtype of renal cancer is? The most common subtype of renal cancer is? Here you can see the biopsy. Okay, and this biopsy is having vacuolated cells. Okay, they are having a clear cytoplasm. Therefore, these are the clear cells. Okay, and therefore, the most common subtype of renal cell carcinoma is clear cell carcinoma. Most common subtype of renal cell carcinoma is clear cell carcinoma. Most common subtype of renal cell carcinoma is clear cell carcinoma. Whereas if they ask you which renal carcinoma has the best prognosis, the answer is which renal carcinoma has the best prognosis. All important चीजें ही discuss कर रहा हूँ मैं. Which renal cancer has the best prognosis? जल्दी से. It is the chromophobe type. Which renal cancer has the best prognosis? It is the chromophobe type. Which renal cell cancer has the best prognosis? Chromophobe type. And on chromophobe type biopsy, on chromophobe cancer biopsy, which type of cells are seen? The cell's shape would be, or the cell appearance would be, the malignant cell will look like the plant cell. Malignant cells will look like the plant cell. So intercalated cells to honge, but they will look like the plant cell. So there would be a plant cell appearance. There would be a plant cell appearance. No issues with this, anybody? कोई दिक्कत है किसी को? So there would be a plant cell appearance. No issues with this. I hope so. Now, what is the treatment of choice? जल्दी से. Investigation बता दिया, CECT. Okay. If you remove the tumor, after that you perform biopsy. तुम बोलोगे sir biopsy कैसे कर ली? After you remove the tumor, resect the tumor, then you perform a biopsy. Okay. So if I talk about the treatment, if the renal cell cancer is less than 4 centimeter, if the renal cell cancer is less than 4 centimeter, the treatment of choice would be surgery. तो दोनों में करेंगे. If it is less than 4 centimeter, then the surgery would be सब पूरी किडनी निकालोगे, थोड़ी निकालोगे. नेफ्रॉन स्पेयरिंग सर्जरी, दैट इज अ पार्शियल नेफ्रेक्टमी. लेस देन 4 सेंटीमीटर, partial nephrectomy. Less than 4 centimeter, partial nephrectomy. Whereas if it is more than 4 centimeter, then total nephrectomy. If it is more than 4 centimeter, then a total nephrectomy is to be done. Okay, less than 4, partial nephrectomy. More than 4, total nephrectomy or a radical nephrectomy we'll call it. Okay, so we will call it a radical nephrectomy. Why radical nephrectomy? Because we will also remove what? Along with that, we will remove the lymph nodes as well. We will also remove the lymph nodes as well. Okay, so 4 centimeter is the cutoff. 7 centimeter नहीं है यार, इतना नहीं है. 4 centimeter is the cutoff. Please remember. ठीक है. For stones it is 2 centimeter. For cancer it is 4 centimeter. Then if I talk about nephroblastoma, nephroblastoma is usually seen in a child who is less than 3 years of age. And what is this renal tumor known as? The renal tumor, which is known as nephroblastoma in a child less than 3 years of age. It is also called as nephroblastoma. यार यूजुअली मोस्ट ऑफ द बुक्स कॉल इट एज 4 सेंटीमीटर. ठीक है, मैं तुम्हें स्क्रीनशॉट डाल दूंगा भले ही बाकी नोट्स के. तो 4 सेंटीमीटर यूजुअली बहुत सारे बुक्स बताते हैं. ठीक है. So it is the Wilms tumor. Yes, Wilms tumor is also called as nephroblastoma. Wilms tumor is also called as nephroblastoma. No issues with this. Wilms tumor called it as Wilms tumor is also called as nephroblastoma. It is seen usually in a child less than 3 years of age. Here also the features would remain same. There would be abdominal mass, there would be flank pain and hematuria. Abdominal mass, flank pain and hematuria. Abdominal lump or mass, it is one and the same thing. Flank pain and hematuria in the child. Okay, so please remember why Wilms tumor is important, because it is associated with some genetic conditions. Okay, it is associated with some genetic condition. Okay, it is due to WT1 या WT2 gene mutation. It is due to WT1 or WT2 gene mutation. ठीक है, Wilms tumor 1 और Wilms tumor 2 gene mutations. ठीक है, and therefore it is associated with other syndromes. Okay, it is associated with either a syndrome called as Dennis-Drash syndrome. It is associated with WT1 is associated with Dennis-Drash syndrome. WT1 is associated with Dennis-Drash syndrome, whereas WT2 is associated with a syndrome. जल्दी जल्दी बताना. Hemihypertrophy, macroglossia, enlarged testis. क्या है? Hemihypertrophy, half side of the body of the child is very good. It is the Beckwith-Wiedemann syndrome. Very good, Ruturaj. It is Beckwith-Wiedemann syndrome. So WT1, it is usually the, just a minute, guys. Visible. WT1, it is the Dennis-Drash syndrome, but WT2, it is usually the Beckwith-Wiedemann syndrome. Important. Then Wilms tumor is important because of the reason, because Wilms tumor will have 3 elements. Okay, it will have epithelial elements, it will have mesenchymal elements, as well as it will have blastomal elements. ठीक है, epithelial elements, mesenchymal elements, as well as blastomal elements. Okay, so all of these 3 elements would be seen in cases of Wilms tumor. Okay, all of these things would be seen in cases of Wilms tumor. ठीक है, so important है, याद रख लेना. So 3 elements are seen. It is the epithelial element, it is the mesenchymal element. अब तो दिख रही है ना. It is the epithelial element, it is the mesenchymal element, and it is the blastomal element as well. ठीक है, important. So that is what is a Wilms tumor. Treatment of choice for Wilms tumor is again a resection. Treatment of choice for Wilms tumor is also resection. Okay, important. That is what is nephrectomy should be done. If I talk about bladder cancer, so bladder cancer, usually the most common symptom of bladder cancer, anybody? Most common symptom of bladder cancer, jaldi batao. Most common symptom of bladder cancer. Earlier symptom is increased urinary frequency. Earlier symptom is increased urinary frequency, but the most common symptom would be painless hematuria. Most common symptom is painless hematuria, whereas the earlier symptom is increased urinary frequency. ठीक है, earliest कोई भी urinary bladder का dysfunction हो, कोई भी pathology हो, there would be increased urinary frequency in the bladder. ठीक है, no issues with this. So please remember, what is the treatment for urinary bladder cancer? If it is a mucosal or submucosal tumor, if it is a mucosal or submucosal tumor, what is the treatment? If it is a mucosal or submucosal tumor, what is the treatment? Cystoscopic resection. What is the treatment? Cystoscopic resection. So you will give go inside with a camera and only perform a cystoscopic resection if it is a mucosal or a submucosal tumor. Okay, but if it is a tumor which is invasive, so invasive tumor ke liye, then you will perform a cystectomy. For invasive tumor, you will perform a cystectomy, right? And the new ileum, okay, the new urinary bladder would be formed with ileum. Okay, no issues with this. Please remember. New urinary bladder is formed with ileum. याद रखना. What is the most common type of urinary bladder cancer? Anybody? जल्दी बताओ. Most common type of urinary bladder cancer. हाँ हाँ करवा रहा हूँ क्या? Most common type of urinary bladder cancer. Most common type of urinary bladder cancer. Very good. It is the transitional cell carcinoma. Most common type of urinary bladder cancer is transitional cell carcinoma. Most common type of urinary bladder cancer is transitional cell carcinoma. And what is the most common site for urinary bladder cancer? Most common site for urinary bladder cancer is mostly it is the lateral wall followed by the trigone. Okay, mostly it is the lateral wall followed by the trigone. Okay, it is the lateral wall followed by the trigone. Okay, so most common site would be the lateral wall. Okay, if please remember, please tell me if a patient is having schistosomiasis. If the patient is having schistosomiasis, then he would be at a risk of developing, very good Vincent, he would be at a risk of developing squamous cell carcinoma of the bladder. If a patient is suffering from schistosomiasis, the most common, screen rotate करूं, कैसी आ रही है स्क्रीन? सही तो आ रही है ना? It is fine now, I feel so. Okay, so in schistosomiasis, the patient is a higher risk of developing squamous cell carcinoma. Okay, no issues with this. And I was talking about bladder cancer treatment. Okay, investigation of choice is definitely a cystoscopy and biopsy. Investigation of choice is definitely a cystoscopy plus biopsy. Investigation of choice is a cystoscopy and biopsy. Okay, if I talk about the treatment, okay, if it is a mucosal tumor, okay, if it is a non-invasive tumor, then the treatment would be resection. Okay, it is a cystoscopic resection. If it is a non-invasive tumor, the treatment is cystoscopic resection. But if it is an invasive bladder cancer, then the treatment would be cystectomy. If it is an invasive bladder cancer, then the treatment would be cystectomy. If it is an invasive bladder cancer, the treatment would be cystectomy. Okay. Then next, if I talk about bladder rupture, guys. ठीक है, bladder rupture की अगर बात करूं, bladder rupture can be, so if I talk about bladder rupture, it would be either an extraperitoneal bladder rupture or an intraperitoneal bladder rupture. More common one is, जल्दी से, more common one is extraperitoneal or intraperitoneal bladder rupture. More common one, I'll try to complete, don't worry. Most common one is extraperitoneal or intraperitoneal. जल्दी से, more common one is extra or intra. Most common is extraperitoneal bladder rupture. The most common cause of extraperitoneal bladder rupture is usually a trauma. It can be a road traffic accident. Okay, it can be a road traffic accident. Okay, important. It can be a road traffic accident. Okay, important. Whereas the most common cause of intraperitoneal bladder rupture is usually due to a over-distended bladder. It is usually due to a over-distended bladder. Okay, so please remember, whenever there is an over-distended bladder, maybe there is some stenosis or constriction at the urethral orifice. Okay, and therefore there is a over-distended bladder, or maybe a patient who is drinking beer almost 8 से 10 बोतलें खत्म हो गई उसकी. ठीक है, so in this condition now there is an over-distended bladder. Or during a surgery, when the patient did not empty the bladder before surgery. Okay, so in this condition, usually the patient will have a over-distended bladder. And if in surgery, like for this over-distended bladder, if you try to retract it and if it is injured, then there can be intraperitoneal bladder rupture. Okay, and intraperitoneal bladder rupture, that means the urine would be going into the peritoneum, and that will cause excessive pain in this patient. Okay, abdominal pain would be there, excessive pain would be there in this patient. Okay, investigation of choice. If I talk about investigation of choice, what is the investigation of choice for extraperitoneal or intraperitoneal bladder rupture? Jaldi se. Investigation of choice for extraperitoneal or intraperitoneal bladder rupture is usually a IVU or a IVP. Okay, so please remember, for intraperitoneal bladder rupture, it is for extraperitoneal bladder rupture, it is usually a cystography कर सकते हो. That is IVU का दूसरा version है. That is what is a cystography. ठीक है, so you will inject a dye into the bladder and you will check for the dye, whether it goes in outside the urinary bladder or into the peritoneum. Okay, so that is what is a cystography in this patient. You can take a X-ray also, you can take a CT also, depends on the availability. Best is definitely a CT. So you can do a cystography. No issues with this, yaad rakhna. And if I talk about the cystography, here you can see in extraperitoneal bladder rupture there would be a teardrop deformity. In extraperitoneal bladder rupture, there would be a teardrop deformity. Whereas in intraperitoneal bladder rupture, there would be a sunburst appearance. Okay, so sunburst appearance is seen in intraperitoneal. Sunburst appearance is seen in intraperitoneal. Sunburst appearance is seen in intraperitoneal. Whereas the teardrop deformity is seen in extraperitoneal. Teardrop deformity is seen in extraperitoneal bladder rupture. No issues with this, anybody? What is the treatment of choice? Jaldi say. What is the treatment of choice, guys? Sorry. What is the treatment of choice? So, emergency में क्या करोगे? Very good. Emergency में first of all, you will insert a Foley's catheter. In emergency, first of all, you will insert a Foley's catheter. Okay. In emergency, you will first of all insert a Foley's catheter in the patient. Okay. If it is an extraperitoneal bladder rupture, please remember, in cases of extraperitoneal bladder rupture, yaad rakhna. Okay. In cases of extraperitoneal bladder rupture, you can perform a drainage. Okay. You can perform a drainage in this patient. Okay. You can perform a drainage in this patient. Whereas in cases of intraperitoneal bladder rupture, you need to perform a laparotomy. In cases of intraperitoneal bladder rupture, you need to perform a laparotomy in the patient. Okay. Because if the urine is gone into the peritoneum, there would be higher chances of peritonitis. There would be higher chances of peritonitis in the patient. Okay. So yaad rakhna, intraperitoneal bladder rupture, you need to perform an exploratory laparotomy and a bladder wash, and a peritoneal wash, that is peritoneal lavage should be done in this condition. Okay. No issues with this. So if it is intraperitoneal bladder rupture, then you need to perform an exploratory laparotomy. Okay. Okay. Exploratory laparotomy. No issues with this. Yaad rakh lena. Okay. And here you will perform a drainage. Here you will perform a drainage and observe. And if required, definitely you will repair the urinary bladder. If required, you will repair the urinary bladder. Agar zyada damage hai, then you will repair the urinary bladder as well. No issues with this. In this, so definitely you will repair it always. Exploratory laparotomy with urinary bladder repair. But in extraperitoneal, you will first of all do a drainage. If required, you will also perform a repair. And what is this? This is what is a rubber catheter which is inserted. This is what is a Foley's catheter looks like. This is what is a Foley's catheter looks like. Okay? So please remember, this is what is a Foley's catheter, which is usually used for urinary retention. It is used for urinary retention cases. Okay, it has a balloon, okay, which helps in fixation of the Foley's catheter. It has a balloon which helps in the fixation. Okay, important. Usually it has two ports. One port is to inflate the balloon, the other port is for the urine. Okay, one port is to inflate the balloon, the other port is for the urine, and it is available in various sizes. Okay, it can be 14 French, 16 French. Okay, so it is the French sizes. Okay. So green for girl, green for girl वैसे तुम depending on the urethral size होता है. Usually for males we use the 16 French Foley's, that is orange color. For girls we use the green colored Foley's, that is usually 14 French. Okay, so 16 French for males, 14 French for females. Okay, no issues with this. Then if I talk about the urethral rupture, so urethra, as we know, urethra is of two types. Urethra is of two types. It is the anterior urethra and posterior urethra. Anterior urethra sorry, it is usually anterior urethra is also called as the distal urethra. So anterior urethra is either the penile urethra and the perineal or bulbar urethra. Okay, it is the penile urethra and perineal or the bulbar urethra. Whereas posterior urethra, it is the prostatic urethra and the membranous urethra. Prostatic urethra and the membranous urethra. Please tell me which is the narrowest portion of the urethra. Which is the narrowest portion of the urethra? Which is the narrowest one-liner? Straight away one-liner, important question. Which is the narrowest portion of urethra? Which is the narrowest portion of urethra? Anybody? Nahi. Membranous urethra is the second narrowest portion. Membranous urethra is the second narrowest portion. Prostatic urethra is the widest part of the urethra. Prostatic urethra is the widest part of the urethra. External urethral meatus, external urethral orifice or external urethral meatus is the narrowest part of the urethra. Yaad rakhna, theek hai? So urethra is either anterior or posterior. Anterior is penile and perineal or bulbar. Posterior is prostatic and membranous. Now if I talk about the rupture of the urethra, more common is anterior or posterior? Jaldi. More common is anterior urethral rupture or posterior urethral rupture? More common is very good. More common is the anterior urethral rupture. More common is the anterior urethral rupture. Most common cause of anterior urethral rupture is usually, most common cause of anterior urethral rupture is again trauma. Most common cause of anterior urethral rupture is again trauma. It can be a road traffic accident, bicycle accident वगैरह. Okay, it can be a road traffic accident. पहले के साइकिल्स में आता था ना वो बीच का खंबा, due to that. Okay, so most common cause is trauma. It is usually due to a road traffic accident. और अगर शराबी है कोई, पीता पीता जा रहा है, and then he did not see this open manhole cover. Okay, so due to this manhole injury, so like this, in this fashion also, that can cause an anterior urethral rupture. So please remember, anterior urethral rupture is caused by trauma. Anterior urethral rupture is caused by trauma. And okay, so manhole covers will cause this. Image came earlier and they asked you which is the injury that these so what is seen with this type of injury? What is seen with this type of injury? So with this type of manhole cover injury, usually anterior urethral rupture is seen. Okay, so with this type of manhole cover injury, usually anterior urethral rupture is seen. Anterior urethral rupture is seen. No issues with this. याद रखना, manhole covers causes anterior urethral rupture. Manhole covers causes anterior urethral rupture. ठीक है? Whereas posterior urethral rupture is due to pelvic fracture. Posterior urethral rupture is due to pelvic fracture. So P for P. ठीक है? What is the triad? So now two things are common in the triad. So two things are usually common in the triad. So first is retention of urine. First one is retention of urine. Okay, these are seen in both of them. Okay, retention of urine. And second is blood at the tip of external urethral meatus. Blood at the tip of external urethral meatus. So please remember, what are the two things in common in both the triads? First is retention of urine hoga. Second, blood at the tip of external urethral meatus. What are the two common things? Blood at retention of urine, and second, blood at the tip of external urethral meatus. So what is the thing which differentiates the hematoma? Okay, so hematoma in anterior urethral rupture is formed in the anterior urethral rupture is formed in the perineum, whereas hematoma in posterior urethral rupture is formed in the pelvis. Okay, so please remember, pelvic hematoma in posterior, whereas perineal hematoma in anterior, perineum hematoma in anterior. ठीक है, याद रखना. The other two things are common: retention of urine and blood at tip of external urethral meatus. They will play with this. They will give you both these options, and they will ask you, for example, which type of hematoma is seen in anterior urethral rupture. So it is the perineal hematoma, and for posterior it is the pelvic hematoma. ठीक है. If you know the location, ठीक है, proximal or posterior urethra would be in the pelvis, anterior or distal urethra would be outside the pelvis. So इससे easy हो जाता है. Investigation of choice, जल्दी से. What is the investigation of choice, anybody? What is the investigation of choice, all of you? Investigation of choice would be urethra है. अभी MCU कहा? MCU is done for bladder. MCU is usually done for bladder. Very good. It is RGU. Please remember, what is the treatment of choice? It is investigation of choices RGU. Investigation of choices RGU. Okay, investigation of choices usually RGU. याद रख लेना, ठीक है? Don't make a mistake over here, guys. Please remember, ठीक है? So investigation of choice is usually a RGU in this patient, ठीक है? So retrograde uretherogram. It is the retrograde uretherogram. What is the treatment of choice? Treatment of choice for anterior urethral rupture and posterior urethral rupture. जल्दी से बताओ. For anterior and posterior urethral rupture, the treatment of choice would be. Just a minute, कोई problem आ रही है. The treatment of choice for anterior urethral rupture and posterior urethral rupture would be repair. Yes, definitely. The treatment of choice would be a suprapubic repair. Okay, it would be sorry, a suprapubic repair. Okay, which approach is used? A suprapubic approach is used. ठीक है? A suprapubic repair is usually done in cases of anterior and posterior urethral rupture. ठीक है? So important. No issues with this, anybody? So याद रखना, repair is usually the treatment of choice in both the conditions. ठीक है? No issues with this. I hope so. Here you can see that there is almost a bladder which is constricted. Okay, there is a narrow bladder which is there. Okay, the size of the bladder has been reduced. Okay, there are multiple perforations. There is multiple damage which has occurred to the bladder. This type of a bladder is actually called as the thimble bladder. This type of a bladder is actually called as a thimble bladder. And thimble bladder is usually a complication or sequel of. Thimble bladder is usually a complication or sequel of. Jaldi se. Thimble bladder is usually a complication or sequel of bladder TB. Very good. It is a complication of sequel of bladder TB. And again, the treatment of choice for bladder TB is also, the treatment of choice for bladder TB is also what? It is ATT. That is your anti-tubercular therapy. It is your anti-tubercular therapy. Important. ठीक है? Then ये इसका आंसर बता दो please. What is this one? कहाँ गया? Okay, this one. So this one is what? Here you can see that the bladder is almost like a Christmas tree. Here the bladder is almost like a Christmas tree. So this is known as the Christmas tree appearance. This is known as the Christmas tree appearance. And Christmas tree appearance of bladder is seen in which condition? Christmas tree appearance of bladder is seen in which condition? Christmas tree appearance of bladder is seen in Christmas tree appearance of bladder. Christmas tree appearance of bladder is seen in. It is seen in cases of neurogenic bladder. So ये image आ चुकी है पहले भी. Don't make a mistake, guys. Okay, this image had come earlier. So Christmas tree appearance of bladder is seen in cases of neurogenic bladder. Okay, Christmas tree appearance of bladder is seen in cases of neurogenic bladder. It is usually seen in cases of neurogenic bladder. No issues with this. Anybody now? Okay, please remember these are the two important things. अलग सी है thimble bladder feature of bladder TB, whereas a neurogenic bladder is gives the appearance of Christmas tree. It gives the appearance of Christmas tree. No issues with this. Important. Next, moving further, talking about this one. A neonate was brought to the emergency room with urinary retention, and child was diagnosed with complete posterior urethral valve with micturating cystourethrogram. What is the emergency or definitive management? So यहाँ पे neonate was brought to with urinary retention, and it is always the male child. ठीक है? So posterior urethral valve is only seen in male child of the family. Okay, posterior urethral valve is only seen in the male child of the family. Right? Important. Please remember, it is usually seen in the male child of the family. ठीक है? And what is the investigation of choice? So as they have told you already, the investigation of choice is the MCU. Investigation of choice is usually a MCU. Investigation of choice is usually a MCU. That is a micturating cystourethrogram. Micturating cystourethrogram. Please remember. Okay, micturating cystourethrogram. No issues with this. Please remember this. Okay, micturating cystourethrogram. What is the emergency or definitive management? Anybody? What is the emergency or definitive management? What is the emergency or definitive management? अरे क्या हो गया? What is the definitive or emergency management? पहले तो emergency management बताओ जल्दी से. The emergency management is usually Foley's catheterization. Emergency management is usually Foley's catheterization. Please remember. Okay, so please remember, if they ask you, if a child has presented to you, a male neonate was brought with urinary retention, okay, and if it is a complete valve, okay, please remember, if it is usually a complete valve, the child would be presenting at the neonatal period. Okay, if it is a complete valve and there is complete obstruction of the urinary stream, then the child will be brought to you in the neonatal period with complaints of urinary retention. Okay, and if it is a partial valve only, then the child would be black. Okay, the child would be brought to you in the childhood. Okay, the child would be brought to you in childhood with complaints of okay, it's brought to you in childhood, then the complaint would be more likely a UTI. So it is brought with complaints of urinary retention in the, whereas a child usually in the OPD with complaints of urinary tract infection. Okay, so in neonate there would be complete posterior urethral valve, whereas in childhood there would be a partial urethral valve. Okay, इसीलिए late presentation होगा if there is a partial urethral valve. Okay, and this urethral valve, the most common site for this urethral valve is actually distal to the verumontanum. It is distal to the verumontanum. What do we mean by verumontanum? It is the elevated portion in the male urethra. It is an elevated portion in the male urethra. So it is this posterior urethral valve, it is usually formed distal to the verumontanum. Okay, so emergency mein you need to relieve the patient from urinary retention, and therefore the emergency management would be Foley's catheterization. Emergency management is Foley's catheterization, whereas the definitive management is what? Definitive management is, please remember, definitive management, all of you have told already. Yes, it is a transurethral, okay, transurethral resection of the valve. Okay, it is a transurethral resection of the valve. So definitive management is usually a transurethral resection of the valve. Okay, so you will resect the valve. Okay, so nowadays we use laser for that, therefore it is called as a fulgration of the valve. Nowadays we use laser for it, and therefore it is called as the fulgration of the valve. Okay, no issues with this. Please remember, PUV is more common. Okay, it is the most common obstructive congenital anomaly of male urethra. It is the most common obstructive congenital anomaly of male urethra. Overall, most common congenital anomaly of male urethra is hypospadias. ठीक है? So it is seen in a male child. Neonate होगा, emergency में आएगा with urinary retention. Child होगा, OPD में आएगा with recurrent UTI. Neonate है तो complete valve हो सकता है. Child है तो partial valve हो सकता है. Investigation of choice is MCU, micturating cystourethrogram. Most common site for PUV or posterior urethral valve is distal to the verumontanum. Emergency treatment is Foley's catheterization. Definitive management is transurethral resection of the valve. It is usually done by fulgration of the valve. ठीक है? यहाँ पे it is the as I told you, urethral rupture mein, usually you need to relieve the patient. So first of all, you will do insert a supracath. And what do we mean by supracath? That is a catheter is inserted. Okay, a catheter is inserted, but you cannot insert a Foley's because the urethra is damaged, and therefore you will insert it from the suprapubic area. Okay, so supracath is inserted. Okay, it is inserted with the help of a trocar. It is inserted with the help of a trocar, and then you repair the urethra if it is required. Okay, if it is a major damage, then you repair the urethra. No issues with this. And this is the MCU of this posterior urethral valve. This is the MCU of valve. You can see there is a gross urinary retention in the child. There is a gross urinary retention, and postal to the urethral valve, distal to the urethral valve. Here you cannot see any dilatation. Okay, distal to the urethral valve, there will be collapse of the ureter. Distal to the urethral valve, there would be a collapse of the urethra, but proximal to it there is a dilated urethra. No issues with this, anybody? Now, if I talk about a neonate who was delivered with preterm and on examination his scrotal sac was empty, ultrasound was performed which reveals right testis in the inguinal canal and the left one in the iliac fossa. What is the diagnosis? So this is a recall question from August examination, guys. Exact question. Please tell me, what is your diagnosis? A child is delivered means less than 37 weeks of gestation, or maybe the child would be premature, less than 34 weeks. In this condition, the child would be at a higher risk of undescended testis. The child would be at a higher risk of undescended testis, and undescended testis is also called as cryptorchidism. Undescended testis is also called as cryptorchidism. So definitely here the child is having undescended testis. Okay, they are not in the scrotal sacs, and therefore the scrotal sacs are empty usually, right? So usually the testis are formed in the abdominal cavity. They are formed in the abdominal cavity, but they descend down usually at birth, okay, into the scrotal sacs, okay, because the temperature of the scrotal sacs is 2 degrees Celsius less as compared to the abdominal cavity, and that is favorable for your spermatogenesis. So यहाँ पे क्या है, right side testis usually it is in the inguinal canal. So usually the testis from the abdominal cavity goes down into the scrotum sac via the inguinal canal. Okay, the testis goes down into the scrotal sac via the inguinal canal. So if the testis cannot go down properly into the scrotal sac, then it can get arrested at the inguinal canal. So if they ask you which is the most common site, if they ask you the most common site of undescended testis, it is usually the inguinal canal. Most common site of undescended testis, it is usually the inguinal canal. Most common site of undescended testis, it is the inguinal canal. Okay, it is the inguinal canal. ठीक है, याद रखना. So here the right-sided testis is in the inguinal canal. That means the right-sided testis is usually undescended. Okay, so right-sided testis is undescended. It has got arrested in the normal pathway, but the left one is not even in the inguinal canal. It is directly in the iliac fossa. That means it is not in its normal position. Therefore, the left-sided testis is ectopic. Left-sided testis is ectopic. So this is important. Okay, so right-sided testis is undescended, but the left-sided testis is ectopic. Yaad rakhna. Okay, no issues with this. So undescended testis or crypto, and the most common would be idiopathic. Most common cryptorchidism is idiopathic. Most common cause of cryptorchidism is idiopathic. Usually it occurs in premature or preterm neonates which are born. Okay, yaad rakhna. And if there is cryptorchidism, please remember, you first examination that you need to do a scrotal palpation. Okay, on scrotal palpation, if the testis are absent, then you can definitely think in terms of undescended testis. What is the investigation of choice to confirm it? Okay, what is the investigation of choice to confirm it? Definitely ultrasound scrotum would be our next thing. Ultrasound abdomen and ultrasound scrotum would be our first line investigation that we will do. Okay, so ultrasound scrotum or the ultrasound abdomen would be a next line investigation. Ultrasound scrotum or ultrasound abdomen would be our next line investigation. But if I talk about the best investigation, If I talk about the best investigation, it is diagnostic laparoscopy. If I talk about the best investigation, it is diagnostic laparoscopy. Please remember, investigation of choice is the ultrasound abdomen and ultrasound scrotum to check for the testes. Best investigation is diagnostic laparoscopy. No issues with this. Treatment of choice is what? Treatment of choice usually for undescended testis. अगर किसी बच्चे में undescended testis है, you need to wait for, very good, you need to wait for a period of at least 4 to 5 months. You need to wait for a period of at least 4 to 5 months. Okay, testis will maximum descend down in a period of 4 to 5 months. Some books say it has maximum 9 months. ठीक है, so maximum 9 months तक testis can descend down into the scrotal sacs. Okay, usual time is usually 4 to 5 months में the testis will descend down into the scrotal sac. Till that, अगर Bacha, if the child is 2 months of age, then definitely the treatment would be observation. Okay, if the child is 2 months of age, then you need to wait and watch. Therefore, the treatment would be observation, wait and watch. Okay, if the child is less than 4 to 5 months or less than 6 months, okay, if the child is less than 6 months, definitely the treatment of choice would be wait and watch. The treatment of choice would be wait and watch. ये ऐसे वाले question इनको बहुत मजा आता है पूछने में. So please be sure with these type of questions where the answer is reassurance, wait and watch. Okay. And if the child is more than 6 months of age, the usual time to perform the surgery is between 6 to 12 months. Usual time to perform the surgery is between 6 to 12 months. And with surgery is performed, usually it is orchidopexy. The surgery performed for undescended testis is orchidopexy. Orchido means testis, pexy means fixation. So the testis is fixed in its normal position in the scrotal sac. That is what is the orchidopexy. And what is the time duration in which we perform orchidopexy? It is 6 to 12 months. Till 6 months, we wait and watch. No issues with this. Next. Now, if I talk about the most common congenital anomaly, as I told you, okay, if I talk about the most common congenital anomaly of male urethra, it is usually hypospadias. Okay, it is usually hypospadias, right? In hypospadias, as we discussed, the opening of the urethra is not on the front, it is rather on the ventral side, it is rather on the downside of the ventral side, right? The most common type here, the opening can be at various places. It can be on the glans penis called as granular. It can be on the coronal or subcoronal. It can be distal, mid, or proximal penile shaft. It can be penoscrotal. It can be scrotal, or it can be perineal as well. Okay, I'll come to that ectopic testis part. यहाँ पे याद रख लो, the most common type of hypospadias is granular. Most common type of hypospadias is granular. Most common type of hypospadias is granular. Okay, please remember, most common type of hypospadias is granular, whereas the least common type of hypospadias is perineal. Least common type of hypospadias is perineal. Least severe type of hypospadias is granular. Least severe type of hypospadias is granular. But the most severe type of hypospadias would be perineal. Okay, no issues with this. Please remember this. Okay. Now, please tell me, investigation की तो कोई जरूरत नहीं है. You can just, it is visible. Okay. What is the treatment of choice? Please tell me. Hypospadias के लिए, what is the treatment of choice and what is contraindicated? Hypospadias में, what is contraindicated? So, treatment of choice for hypospadias. Please remember. Sorry, guys. The treatment of choice for hypospadias is rebuilding or reconstruction of urethra, and that is what is called as urethroplasty. Please remember. Okay, and this urethroplasty is done with, please remember, urethroplasty is usually done with the foreskin or the prepuce. Okay, urethroplasty is usually done with the foreskin or prepuce, and therefore to we need this foreskin or prepuce for urethroplasty, and therefore circumcision would be absolutely contraindicated. Circumcision is contraindicated in patients of hypospadias. Okay, please remember, you will perform a urethroplasty in this patient. Okay, you will reconstruct the urethra again with the help of foreskin or the prepuce. Okay, no issues with this. I hope so. Moving further. Now, talking about this condition. Usually, if a patient is having hypospadias, okay, there can in the penis. Okay, there can be such a downward curvature in the penis, and this downward curvature of penis in a patient of hypospadias is known as downward curvature. It is not peroneus. Peroneus is due to a fibrous plaque which is there in the penis. Okay, it is also a downward curvature. Okay, but here it is associated with hypospadias. In a patient of hypospadias, when there is a downward curvature of penis, it is usually called as a chordee. Okay, please remember, it is usually called as a chordee, a downward curvature in a patient of hypospadias. And if there is chordee, you need to do a chordee correction. correction. Please remember. And along with urethroplasty in the patient. Okay. No issues with this. Yaad rakhna. Then if the patient is unable to retract the foreskin, inability to retract the foreskin is called as phimosis. Inability to retract the foreskin is called as phimosis. Inability to retract the foreskin is called as phimosis. And phimosis is normal up to what age? Phimosis is normal up to what age? Anybody? Phimosis is normal up to what age? Jaldi say. And if the patient is unable to bring back the foreskin, if the patient is unable to bring back the foreskin, okay, bring back the retracted foreskin, then that is what is called as paraphimosis. If the patient is unable to bring back the retracted foreskin, that is what is called as paraphimosis. It is due to swelling which is seen. Okay, there would be a swelling which is seen around the foreskin. Okay, and therefore the patient is unable to retract the foreskin again on the glance. Okay, so till 3 to 4 years of age, very good. Till 3 years of age usually, okay, till 3 years of age usually, phimosis is physiological or phimosis is normal. But after 4 years of age, phimosis would be abnormal. Okay, the most common cause is usually balanoposthitis. Okay, inflammation of your glans penis. Okay, that is what is called as balanoposthitis. No issues with this. Moving further. If I move further, talking about the next one, guys. Here you can see there is priapism in the patient. Priapism is what? Anybody? Priapism is what? Priapism is painful, persistent penile erection. Okay, priapism is what? Painful, persistent penile erection lasting for more than 4 hours. Okay, painful, persistent penile erection lasting for more than 4 hours. Painful, persistent penile erection lasting for more than 4 hours. It is called as usually priapism. Priapism can be due to a very highly violent sexual intercourse. Okay? It can be due to a overdosage of your sildenafil. It can be due to a papaverine injection into the corpora cavernosa. All of these can be the causes. Okay? So priapism. Most common cause of priapism overall, anybody? Most common cause of priapism overall. All of these can be the causes, but the most common cause of priapism overall, anybody? Most common cause of priapism overall. It is idiopathic. Most common cause of priapism overall is idiopathic. Most common cause of priapism overall is idiopathic. Please remember, most common cause in children is definitely sickle cell anemia or leukemia. Most common cause in children is usually sickle cell anemia or leukemia. Whereas, what is the treatment? Most common cause overall is idiopathic. Most common cause in children is sickle cell anemia or leukemia. Whereas, what is the treatment? Treatment should be, so the penis is erected for more than 4 hours now. Okay, so you need to perform the primary treatment. Please remember, not always shunting would be done. Okay, primary treatment kya hogi? So first line management, if they ask you, then it should be aspiration of blood. Okay, it should be aspiration of blood from the corpora cavernosa. Aspiration of blood from the corpora cavernosa would be done. Okay, and that will relax the penis. Okay, aspiration of blood from the corpora cavernosa. If this fails, then we will perform a cavernosa granular shunt. If this fails, then we perform a cavernosa granular shunt. No issues with this. Please remember this, important. Next, whatever you were talking was this one. Here you can see there is a fibrous plaque in the penis. Okay, there is a fibrous plaque in the penis, and therefore due to the fibrous plaque in the penis, there is a curved erection that the patient will get. Okay, so there would be a curvature, and it is usually upward, not a downward curvature like Cordy. Okay, here it would be mainly a upward curvature which is seen, and it is more prominent in cases of erection. It is more prominent in cases of erection. This is what is called as Peyronie's disease. This is what is called as Peyronie's disease. So usually, what is the treatment for Peyronie's disease? Anybody? It is due to a formation of fibrous plaque. The penis, when erected, it would be it would be curved towards that particular side. Okay, it is usually an upward curvature which is seen. It is usually upward curvature. What is the treatment? Anybody? What is the treatment? No, not excision. Treatment. First, please remember, you should give reassurance. Okay? The first line management is reassurance because it is a self-limiting condition. It is reassurance because it is a self-limiting condition. It will go by itself. Okay. If the patient insists, nahi mujhe treatment chahiye hi chahiye, ya fir if the like it is lasting for more than 6 months now, then definitely a procedure which is performed is known as the Nesbit's operation. Then a procedure which is performed is known as the Nesbit's operation. What do we do in Nesbit's operation? Apply a non-absorbable suture over here. Okay, so apply a non-absorbable suture over here, so he will get a straight penile erection. Okay, no issues with this. Please remember this. This is what is a Nesbit's operation. Okay, no issues with this. First line is definitely reassurance. Okay, first line is definitely a reassurance. Okay. If the fibrous plaque is very much big, then definitely you can resect it. Okay, if the fibrous plaque is bigger in size and if it is not even the patient is unable to get the straight penile erection even after a Nesbitt procedure, then you can go for cutting or excision of that fibrous plaque. Okay, what is this condition called as? Here you can see there is gangrene. Okay, here there is almost gangrene of the perineum. There is gangrene of the perineum, but the testes are not usually involved. There is gangrene of the perineum, the penis is involved. Okay, so everything, it is usually due to poor hygiene in males. Okay, there would be abscess formation. It can be a sequel of perianal fistulas, perianal abscess in a patient. What is this? This condition is actually called as a Fournier's gangrene. This condition is actually called as the Fournier's gangrene. So this one image, please remember, it is a Fournier's gangrene. So infection or ischemia of the perineum on a long term or a long duration can lead to Fournier's gangrene. Okay, please remember this. Then if I talk about penile cancer now, okay, if I talk about penile cancer, what is the most common type of penile cancer? Anybody? Adeno or squamous cell? Most common type of penile cancer is adeno or squamous cell. Most common type of penile cancer is adeno or squamous cell. Very good. It is the squamous cell carcinoma. Most common type of penile cancer is squamous cell carcinoma. Okay. Most common type of penile cancer is usually squamous cell carcinoma. What is the most common site for penile cancer? Anybody? What is the most common site for penile cancer? What is the most common site for penile cancer? Jaldi jaldi answer karo. Most common site for penile cancer is usually glans or the prepuce. Okay, दोनों अगर option में होंगे साथ में glans plus prepuce, that is the best answer to be given. If not, then you can prefer glans or prepuce. Okay, so most common site is the glans or the prepuce. That is your foreskin. ठीक है. Most common cause would be, most common cause is poor hygiene. Please remember the most common cause is usually poor hygiene in the patient. Investigation of choice. बाहरी दिख रहा है, right? So बाहरी दिख रहा है तो definitely it is biopsy. Okay, so please remember investigation of choice is usually a biopsy. Investigation of choice is usually a biopsy. Either a excisional or a incisional biopsy would be done. Staging investigation of choice, ये बता दो, तब तक मैं ये बता रहा हूँ. So this is what is a penile cancer looks like. Okay, so in penile cancer please remember there would be a ulceroproliferative growth. बस proliferative growth नहीं दिखेगी, ulcers भी दिखेंगे साथ में. Okay, so here you can see a ulceroproliferative growth. Okay, here you can see a ulceroproliferative growth on the penis. It is usually suggestive of a penile cancer. ठीक है. So what is the staging investigation of choice? Staging investigation of choice would be, staging investigation of choice is definitely MRI. Please remember MRI. अगर PET CT option में है then you can mark it better. Okay, because it will also help you for distant metastasis. वो देखने के लिए भी PET CT एक साथ मदद कर देगा. But usually for normal staging the investigation of choice is MRI. Okay, but if you have PET CT in option, then that definitely that is the best investigation because you can look for other distant metastasis at the same time as well. ठीक है, याद रखना. Then treatment of choice would be, anybody? Treatment of choice would be, so treatment of choice would be if we can leave behind more than 2 centimeters of penis. Okay, अगर वो बस foreskin involved है, then we can perform a circumcision. Not in every case. Okay, please remember. If we can leave a more than 2 centimeters of penis, if we can leave more than 2 centimeters of penis stump behind, then we will do a partial penectomy. If we can leave a more than 2 centimeters of stump behind, more than 2 centimeters का अगर stump बचता है, then we can do a partial penectomy. But if less than 2 centimeters of stump would be left behind, okay, if less than 2 centimeters of stump is left behind, then we will do a total penectomy. Then we will do a total penectomy. And after total penectomy, where would be the urethra? So the urethral opening would be made in the perineum. Okay, so the urethral opening would be made in the perineum. याद रखना. So perineal urethroplasty is done along with total penectomy. Along with total penectomy, what is the other procedure? Perineal urethroplasty. No issues with this. More than 2 centimeter अगर बचता है, partial penectomy. Less than 2 centimeter अगर बच रहा है, then perform a total penectomy itself. ठीक है. What is the sentinel lymph nodes? Which are the sentinel lymph nodes? Anybody? जल्दी से. The sentinel lymph nodes for penile cancer. So sentinel lymph nodes का procedure, sentinel lymph nodes का concept is the first draining lymph nodes of a cancer are called as sentinel lymph nodes. ठीक है. And those were first described in penile cancer itself by a scientist known as Cabana, and therefore it is known as the Cabana's lymph node. Therefore those are known as the Cabana's lymph node. Okay, so sentinel lymph nodes of penile cancer are the Cabana's lymph nodes. Okay, so sentinel lymph nodes of penile cancer are the Cabana's lymph node. Anybody? Which are the sentinel lymph nodes for gallbladder cancer? The sentinel lymph nodes for gallbladder cancer. जल्दी से. The sentinel lymph nodes for gallbladder cancer. जल्दी से. Important नाम है, so ये आ सकता है. Those are known as lymph nodes of Lund. Okay, please remember those are known as lymph nodes of Lund. The sentinel lymph nodes for gallbladder cancer. Okay, don't forget it. Okay, and that is why the Carrot triangle becomes important. That is why the Carrot triangle also becomes important, because the lymph nodes are Lund are present in the Carrot triangle. Whereas the most common cause of death in penile cancer, usually when there is a ulceroproliferative growth in penile cancer, this can also extend up to the femoral vessels or the iliac vessels. And if there is involvement of the femoral or iliac vessel, there would be excessive hemorrhage. So a torrential hemorrhage would be there, or a excessive hemorrhage would be there. And torrential hemorrhage is actually the cause of death in patients of penile cancer. Torrential hemorrhage is the cause of death in cases of penile cancer. Then if I talk about this condition, what is this called as? Anybody? यहाँ पे दिख रहा है. So this a child presents to you with the inguinoscrotal swelling. Okay, a child has presenting to you. Question है मेरा, a child has presented to you with a inguinoscrotal or only a scrotal swelling. Inguino भी हो सकती है, scrotal भी हो सकती है. So यहाँ पे scrotal है. So I am writing it as, चलो inguinoscrotal लिख देता हूँ. So here it is only scrotal, but it can be a inguinoscrotal swelling as well. Okay, so inguinoscrotal swelling in a child, and when you perform a trans elimination test, then the cystic swelling is brilliantly trans-illuminant, and the cystic swelling is brilliantly trans-illuminant. Okay, the torch, when you put the torch on one side, due to the fluid inside the scrotum, there would be a brilliant trans-illumination which is seen. So definitely here the diagnosis would be hydrocele. Okay, here the diagnosis would be hydrocele. Important, please remember this. Okay, so hydrocele is due to accumulation of fluid in. Hydrocele is due to accumulation of fluid in. Please tell me, jaldi se. Hydrocele is due to accumulation of fluid in. Most common cause of hydrocele, as we have discussed, most common cause of hydrocele is filariasis. Most common cause of hydrocele is filariasis. Most common cause of hydrocele is filariasis. Very good. Please remember, hydrocele is due to accumulation of fluid in the processus vaginalis. Okay, please remember, hydrocele is due to accumulation of fluid in the processus vaginalis. Accumulation of fluid in the processus vaginalis. So this processus vaginalis is usually the one which brings down the testis into the scrotum, That is what is the processus vaginalis. It obliterates after birth. But if this processus vaginalis remains patent and there is accumulation of fluid, that would lead to formation of a hydrocele. And hydrocele, on palpation, it would be a cystic swelling. On ultrasound, we can do a ultrasound scrotum. On that, you can see a blackening. That means it is suggestive of fluid. And on trans-illumination, it will be brilliantly trans-illuminant. Okay, most common causes filariasis. There can be various types of hydrocele. The most common type of hydrocele, anybody, jaldi say. Sorry, the most common type of hydrocele, when the swelling is only limited up to the scrotum. Okay, when the swelling is only limited up to the scrotum. So the most common type of hydrocele, anybody? Most common type of hydrocele is anybody? Most common type of hydrocele when the swelling is only limited up to the scrotal sac. It is called as the vaginal hydrocele. Most common type of hydrocele is a vaginal hydrocele. Most common type of hydrocele is a vaginal hydrocele. Most common type is vaginal hydrocele. But when you see a swelling above the scrotal sac also, so when you see a inguinoscrotal swelling, that means accumulation of fluid in the scrotum as well as in the inguinal canal, then this one is called as the infantile hydrocele. Very good. It is called as the infantile hydrocele. This one is called as the infantile hydrocele. And when you can see that the complete processus vaginalis is patent, and therefore there is a connection with the abdomen also. Okay, so a connection with abdomen from the scrotum. Okay, so a patent connection between the scrotum and abdomen due to a patent processus vaginalis. Okay, so this is called as a communicating hydrocele. Okay, so when there is a accumulation of fluid in the scrotum, in the in the inguinal canal, as well as it is connecting with the abdominal cavity, this one is actually called as a communicating hydrocele or a congenital hydrocele. And when the cystic swelling is only limited up to certain part of the cord, then this is called as the encysted hydrocele of the cord. It is called as the encysted hydrocele of a cord. No issues with this. Most common is vaginal overall. Inguinoscrotal swelling is seen in infantile hydrocele. Okay, communicating hydrocele is a congenital hydrocele. And in cases of congenital hydrocele, what is the treatment of choice? Rest all are treated differently, but congenital hydrocele is treated differently. Jaldi se. Treatment of choice for congenital hydrocele. And congenital hernia is same. Treatment of choice for congenital hydrocele and congenital hernia is same. Jaldi. Question tha. Very good. It is herniotomy. The treatment of choice for congenital hydrocele is herniotomy. Jaldi se batao at which age it is performed. Okay. The treatment of choice for congenital hydrocele is herniotomy. The treatment of choice for congenital hydrocele is herniotomy. Please remember. Okay. It communicates with the peritoneal cavity, and here it is usually performed at 3 years of age. It is usually performed at 3 years of age. Commonly, it is performed at 3 years of age. After 3 years of age. After 2 के बाद तो नहीं करते. Usually हम 3 तक wait करते. Okay. After 3 years of age. Otherwise, till 3 years of age, it can be self-resolved also. Most of the cases, they are self-resolving as well. ठीक है. No issues with this. याद रख लो ये. Next, if I talk about hydrocele in general, what is the treatment of choice for hydrocele in general? Jaldi se. The treatment of choice for hydrocele in general. The treatment, the surgeries that we perform. So if it is a small hydrocele, we can just do a plication surgery, and that is called as a Lord's plication. If it is a small hydrocele, we can do a plication surgery, and that is what is called as a Lord's plication surgery. But if it is a large hydrocele, we need to do a eversion of the sac. If it is a large hydrocele, we need to do a eversion of sac, and that is what is called as a Jaboulet's eversion procedure. That is what is called as a Jaboulet's eversion procedure. So please remember, if it is a small hydrocele, Lord's plication. Small hydrocele, Lord's plication. Okay, small hydrocele, Lord's plication. Whereas large hydrocele, Jaboulet's eversion procedure. Here, you will cut the hydrocele, you will drain the fluid and evert the sac and suture it. Okay, you will evert the covering of the testis and you will suture it back. Okay, so tunica vaginalis is separated, it is everted, and it is sutured from the backside. Okay, so yeah, that is what is the Jaboulet's eversion procedure. No issues with this. Please remember the Jaboulet's eversion procedure. Important. Then anybody, Lord's surgery or Bascom surgery is the treatment of choice for which condition? Lord's surgery or Bascom surgery is also the treatment of choice for which condition? Jaldi se. Lord's or Bascom surgery is the treatment of choice for which condition? Lord's or Bascom surgery is the treatment of choice for which condition? Jaldi se batao. Lord's or Bascom is the treatment of choice for which condition? Arey? Lord's or Bascom surgery is the treatment of choice for pilonidal sinus. It is the treatment of choice for pilonidal sinus. Please remember, Bascom surgery is a plastic reconstruction of the usually the pilonidal sinus, and Lord's surgery is usually excision of the multiple pits and sinuses. Okay, Lord's surgery is the excision of the multiple pits and sinuses. क्या हुआ था हमने देखा था ना. So yeah, after you perform these, then you perform a flap procedure. So it is usually a Lord's surgery or a Bascom surgery which is done for pilonidal sinus. ठीक है, in prone position जो मैंने बोला था कल, jeep drivers or bottoms disease it is called as, multiple pits and sinuses, hairy gluteal slim, most common site natal cleft, all of these. ठीक है. Now next question over here. A 15-year-old male presents with sudden severe scrotal and abdominal pain. A 15-year-old male presents with sudden severe scrotal and abdominal pain. On elevating the scrotum, his pain is not relieved. Diagnosis and management. Jaldi. Almost, I hope all of you are quite aware of with these topics now. Right. Here the diagnosis is testicular torsion. Right. Important it is. Okay. Testicular torsion. Testicular torsion is common in which age group? It is usually common in young adult males. Okay. Testicular torsion is common in young males. Okay. More commonly in the adolescent age group. याद रखना. ठीक है. The patient will present to you with sudden severe abdominal pain and scrotal pain is there. Okay, and when you elevate the scrotum, the pain is not relieved. Okay, the other differential diagnosis for usually testicular torsion is a condition which is infective or inflammatory in etiology. Over there, if you elevate the scrotum, the pain would be relieved. Okay, so what is the name of this test which helps us differentiate between these two? Very good, Balinda. It is the French test. Okay, it is the French test. So please remember, French test will help us differentiate which two conditions? Testicular torsion from. So in testicular torsion, if we perform the French test, that means if we elevate or lift up the testis, then definitely there would be no pain relief. Rather, the pain will increase in cases of testicular torsion. That is what is a French test. Whereas French test would be positive in cases of epididymoorchitis. French test is positive in cases of epididymoorchitis. When we elevate the testis, there would be pain relief. When we elevate the testis, there would be pain relief in the patient. Okay, no issues with this. So please remember testicular torsion. Okay, so testicular torsion is usually due to this deformity in the patient. Okay, there is high investment of the tunica vaginalis. As we saw here, you can see the tunica vaginalis is covering the testis properly. Okay, the tunica vaginalis is covering the testis. Okay, the tunica vaginalis is covering the testis properly till the bottom. But if the tunica vaginalis did not cover the testis till the bottom, it is only a highly investing tunica vaginalis, then the testis would be like a clapper in the bell. It would be like a clapper in the bell, and this is what is called as the bell clapper deformity. It is called as a bell clapper deformity. And in cases of bell clapper deformity, there is a high chances of testicular torsion. In bell clapper deformity, there are high chances of testicular torsion. No issues with this. Yaad rakho. Now, please tell me what is the treatment. Investigation of choice, definitely it is a clinical diagnosis. Okay, investigation nahi hota hai. Here we will do a clinical diagnosis, and just to differentiate it from epididymal orchitis, we will do a French test, which would be negative in cases of testicular torsion. The pain would not be relieved, first thing. Along with that, if you have a ultrasound, then you can do a ultrasound scrotum immediately. Okay, but it is usually a clinical diagnosis most number of times. Okay, here the patient would have a sudden severe abdominal and scrotal pain. There would be redness, there would be swelling in the scrotum. Okay, redness, swelling in the scrotum. There would be high grade fever or low grade fever would be there commonly. High grade is not very much common, low grade fever is much more common. So this is what is a clinical diagnosis of testicular torsion. So if it is a viable testis, that means if the patient presents to you within 6 to 12 hours, if the patient presents to you within 6 to 12 hours, then you can save the testis, right? The testis has not undergone any ischemia or necrosis as such as of now. So if it is a viable testis within 6 hours, if the patient presents to you, then you will try to save the testis. Okay, then you will try to save the testis. That means derotate and fix the testis. Okay, derotate and fix the testis. And testis fixation is called as, जो हमने अनडिसेंडेड टेस्टिस में भी किया, टेस्टिस फिक्सेशन इज कॉल्ड एज वेरी गुड ऑर्काइडोपेक्सी. टेस्टिस फिक्सेशन इज कॉल्ड एज ऑर्काइडोपेक्सी. सो derotation and orchidopexy, derotation and orchidopexy would be done in cases of viable testis. ठीक है, whereas non viable testis में if the patient presents to you after 12 hours or after 6 hours, some books say 6 hours, some books say 12 hours. ठीक है, so after 12 hours usually or after 6 hours, if the testis is non viable now, that means वो बचा ही नहीं जा like this. Okay, the blood supply is completely gone, it is a gangrenous testis almost, then you need to remove the testis. That means orchidectomy would be done. Orchidectomy would be done. Important. Yes, जो तुम सब बता रहे थे ना, immediate exploration, definitely it is the treatment of choice for viable or non-viable, does not matter. It is immediate exploration definitely for viable testis. If it is viable, then definitely will derotate and orchidopexy would be done. If it is non-viable, then orchidectomy is done. And after both of these procedures, whether it is orchidopexy or orchidectomy, the most important thing to be done is a contralateral orchidopexy. So that means if the right testis was affected and it was operated, left testis should also be fixed properly in its position, because if there is a bell clapper deformity, it would be in both the testes. Okay, therefore contralateral orchidopexy is also done. Please remember, contralateral orchidopexy is also done in case of testicular torsion. No issues with this. क्या हुआ, किसी ने बोला horizontal line concept वाला, यार वो usually तुम्हें नहीं पूछा जाता. It is a question of INICT, not even asked in इसमें. That is for the signs. ठीक है, so the signs which are usually seen. So apart from French test, there are multiple other signs which can be there. Angel sign वगैरह होती है, and that is what is the horizontal line concept. ठीक है, so it is not important. At least remember the important things. That is more important. These are the most important things. Here you can see what is there. You can see a abnormal dilatation and tortuosity. Here you can see a abnormal dilatation. Here you can see a abnormal dilatation and tortuosity of which veins? Of the testicular veins. Which plexus of the testicular veins? Anybody? Which plexus of testicular veins? Sorry. Which plexus of testicular veins? Anybody? Very good. Abnormal dilatation and tortuosity of the pampiniform plexus of the veins. It is due to the abnormal dilatation and tortuosity of the pampiniform plexus of the veins. Pampiniform plexus of the veins, and this condition is called as varicocele. This condition is called as varicocele. Okay, and varicocele, if we palpate the varicocele, definitely the patient, most of the condition, the patient in initial stages would be asymptomatic. In initial stages, the patient is asymptomatic, but in the later stages, the patient will have a dull aching pain. Okay, the patient will have a dull aching pain would be there. Then there would be increase in the size of the scrotal sac, as you can see, and there would be dilatation and tortuosity of these veins which can be palpated, and on palpation it will feel like a bag of worm. So bag of worm appearance or bag of worm feel is seen in cases of varicocele. Bag of worm feel is seen in cases of varicocele. Bag of worm feel is felt in cases of varicocele. No issues with this. Now, varicocele can be due to multiple other conditions. Whenever there is increased abdominal pressure, intra-abdominal pressure increases, that can cause varicocele in a patient. Okay? So maybe there is abdominal tumor or there is ascites, long-standing ascites in a patient. So all of these can be causes of varicocele usually. Okay? whenever there is increased abdominal pressure, as we saw in this one yesterday also. In varicose veins also the cause was same, increased intra-abdominal pressure. Okay, what is the most common cause of varicocele? Anybody? What is the most common cause of varicocele? Jaldi se. Most common cause of varicocele is again idiopathic. मैंने बोला बहुत सारी causes हो सकती है, but the most common cause is idiopathic. The most common cause of varicocele is idiopathic. Most common cause of varicocele is usually idiopathic. Please remember, investigation of choice. This is important और ये आना चाहिए सबको अभी. As I told you, vessels है कोई भी non-invasive. Very good, very good. Investigation of choice for varicocele is a Doppler. Okay, investigation of choice for varicocele is a color Doppler. Investigation of choice for varicocele is a color Doppler. Color Doppler, normal Doppler, जो भी available है. So we will do that. Okay, treatment of choice. Treatment of choice would be anybody. जल्दी से. Treatment of choice would be a Paloma's operation. What do we do in Paloma's operation? We will do a Paloma's operation. क्या करते हो तुम? Paloma's operation में you will do a ligation. Okay, important. High ligation should be done. Okay, please remember, high ligation is usually done in this patient. Okay, so ligation is usually done. Okay, so that is what is your Paloma's operation. Okay, that is what is your Paloma's operation. Along with that, the other choice is also sclerotherapy. The other choice is also sclerotherapy. Important. Please remember, high ligation is done usually in Paloma's operation, or we can inject a sclerosing agent in this vessels. Okay, that is what is the sclerotherapy. Sodium tetradecyl sulfate is the most common sclerosing agent used. अगर वो कहीं भी पूछे किसी भी टाइप के ब्लीडिंग में स्क्लेरोथेरेपी अगर करना है, the most common sclerosing agent used nowadays is sodium tetradecyl sulfate. So important है, please remember this. ठीक है, no, don't worry. Next one is the most common testicular tumor. Anybody? The most common testicular tumor in children is. Most common testicular tumor in children is. Please let me know. Most common testicular tumor in children is. Very good. It is the yolk sac tumor. Most common testicular tumor in children is yolk sac tumor. Most common testicular tumor in children is yolk sac tumor. Okay, please remember, most common testicular tumor in adults is. Most common testicular tumor in adults is not teratoma. Teratoma is common in adults usually. Okay, most common testicular tumor in child is a yolk sac tumor. Most common testicular tumor in adults is a seminoma. Most common testicular tumor in adults is a seminoma. Important. And the most common testicular tumor in elderly would be. Most common testicular tumor in elderly would be lymphoma. Very good. Most common testicular tumor in elderly is lymphoma. So most common testicular tumor in children, yolk sac tumor. Most common testicular tumor in adults, seminoma. And most common testicular tumor in elderly, lymphoma. Okay, please remember this. If they ask you what is the most common cause of adult testicular tumor or most common cause of seminoma, what is the most common cause of seminoma? Anybody? Most common cause of seminoma. Very good. It is undescended testis. It is cryptorchidism. Okay. Most common cause of seminoma is usually undescended testis or cryptorchidism, when the testis is not able to descend down properly into the scrotal sac. Okay. That is what is your undescended testis. Most common cause of seminoma. No issues with this. Then if I talk about the tumor marker, please let me know the tumor marker for testicular tumors. The tumor marker for testicular tumors. Please let me know the tumor markers for testicular tumors. Okay. It is LDH, that is lactate dehydrogenase. Then you can also use alpha fetoprotein, and third is beta SCG. So it is lactate dehydrogenase, LDH. Second is alpha fetoprotein, and third is beta SCG. Now let me know, please, important it is. So usually the testicular tumors are divided as seminomatous tumors and non-seminomatous tumors. Okay, seminomatous tumors would not show positivity for which testicular which tumor marker. Seminomatous tumors are negative for which tumor marker? Seminomatous tumors are negative for which tumor marker? Important. Seminomatous tumors are negative for which tumor marker? Anybody? So they are negative for alpha fetoprotein. Please remember, seminomatous tumors are negative for alpha fetoprotein. Seminomatous tumors are negative for alpha fetoprotein. They are positive for LDH or beta SCG, but negative for AFP, alpha fetoprotein. And the treatment of choice would be, in cases of testicular tumors, the treatment of choice would be, definitely we need to remove the testis. It is a high inguinal orchidectomy. Okay, the treatment of choice is high inguinal orchidectomy. The treatment of choice is high inguinal orchidectomy. Treatment of choice is high inguinal orchidectomy. No issues with this. Then if I talk about prostate now, okay, so prostate gland is usually 20 to 35 grams in weight. Okay, it is usually surrounding your posterior urethra, and therefore it is called as a prostatic urethra, which passes in between the prostate gland, right? There are two lobes usually, there are usually mainly two lobes on the both the sides of the urethra. So that is what is a prostate gland, right? So please let me know if I talk about the first condition, that is BPH, benign prostatic hyperplasia. The most common age group for BPH or benign prostatic hyperplasia is, the most common age group for BPH is, the most common age group for BPH is usually elderly males. Okay, the most common age group for BPH is usually elderly patient. Okay, it would be elderly patients. Please remember this. Okay, most common site for BPH, anybody? So I hope all of you are quite aware that prostate is usually divided into 5 anatomical lobes. Okay, prostate is divided into 5 anatomical lobes. Okay, anterior, posterior, median, and 2 lateral lobes. Okay, 5 anatomical lobes, and it is divided into 3 surgical McNeil zones. It is divided into 3 surgical McNeil zones. Okay, that is central zone, transitional zone, and a peripheral zone. Central, transitional, and a peripheral zone. So please let me know what is the most common site for BPH. Most common site for BPH would be the medial lobe. Okay, if I talk about the lobes, most common site for BPH would be the medial lobes on the lateral lobes. Most common site for BPH would be the medial lobe and the lateral lobe. Whereas if I talk about the zone, the most common site for BPH would be the transitional zone. Most common site for BPH would be the transitional zone followed by the central zone. Okay, most common site would be the transitional zone followed by the central zone. No issues with this. Investigation of choice, jaldi se. Investigation of choice for BPH. So definitely if a patient comes to you with decreased urinary frequency. So what are the complaints of BPH patient? If there is hyperplasia or hypertrophy of the prostate gland, definitely the urinary stream would be affected because the urethral orifice would be narrowed down, right? Therefore, the patient will have urinary retention. There would be increased urinary frequency, but there would be intermittency or hesitancy. Okay, the urinary stream will come and stop, come and stop. So the initial investigation that I will do if a patient comes to me, first of all, I will do a digital rectal examination. On that, I can feel a enlarged prostate. Okay, anteriorly, I can feel a enlarged prostate usually. Okay, investigation of choice would be a investigation of choice, important. Investigation of choice would be a uroflowmetry. Please remember, investigation of choice would be a uroflowmetry. I will check for the urine outflow. Okay, investigation of choice would be a uroflowmetry. Okay, investigation of choice is usually a uroflowmetry in this patient. No issues with this. Yaad rakhna. Along with that, I can also do a ultrasound. Okay, so along with that, I can do a ultrasound, and on ultrasound, I can find a post-void residue. That means after urination, there would be some amount of urine which is still left behind. Okay, and the post-volume residue would be more than 100 ml. If the post-volume residue is more than 100 ml, it is suggestive of urinary retention. Okay, and that can be usually used for the diagnosis of BPH. Okay, so uroflowmetry, which will show hesitancy or intermittency, and second ultrasound, which will show me a more than 100 ml of post-void residue in the patient. What is the drug of choice for BPH? I hope all of you are quite aware now. We have discussed pharma. Drug of choice for BPH. Very good. It is tamsulosin. Drug of choice for BPH is tamsulosin. It belongs to which group? So either tamsulosin or silodosin. Okay, it is tamsulosin or silodosin. Alpha, non-selective alpha blocker, or alpha 1 blocker, or a selective alpha 1A blocker. So please remember, tamsulosin or silodosin or a selective alpha 1A blocker. Tamsulosin or silodosin or selective alpha 1A blocker. And non-selective alpha 1 blocker is prazosin and terazosin. Okay, so non-selective alpha 1 blockers are prazosin and terazosin. And prazosin and terazosin are usually used as a drug of choice for BPH in hypertensive patient, because the most common side effect of prazosin, as we have discussed, it is postural hypotension. Therefore, they are used in hypertensive individuals only. Otherwise, we have a drug known as tamsulosin, which is the drug used to reduce the size of the prostate. So usually prostate size increases due to the active form of testosterone, which is known as DHT, dihydrotestosterone, and it is converted. Testosterone is converted to DHT by enzyme known as 5-alpha reductase. So definitely, if we need to reduce the levels of DHT, dihydrotestosterone, we need to inhibit the enzyme known as 5-alpha reductase. So a 5-alpha reductase inhibitor, it is finasteride. Very good. The 5-alpha reductase inhibitor is known as finasteride is used. Okay, finasteride. Other drugs can also be used. Very good. But finasteride is the drug of choice to reduce the size of the prostate. Okay, overall, it is tamsulosin only. Then if I talk about prostate cancer, please remember, sorry, if I talk about the prostate cancer, then what is the most common site for prostate cancer? Anybody? If I talk about the lobes, it is usually the peripheral lobe. So all PPP you need to remember. So prostate cancer, posterior lobe, peripheral zone. Prostate cancer, posterior lobe, peripheral zone, posterior lobe and peripheral zone, posterior lobe and peripheral zone is the most common site of prostatic cancer. Again, prostatic cancer is the most common cancer in elderly patient. Okay, most common cancer in elderly males. If they ask you which is the most common cancer in elderly males, answer is prostate cancer. If they ask you most common cancer in elderly males, answer is prostatic cancer. And there was a question in August examination that which of the following cancer is usually a hormonal cancer or which can be treated with hormonal therapy. Okay, the answer was prostatic cancer. So prostatic cancer can be treated with hormonal therapy. Usually the later stages, the advanced stages of prostatic cancer are treated with hormonal therapy. Okay, if I ask you about screening, what is done for screening of prostatic cancer? What is done for screening of prostatic cancer? Very good. A digital rectal examination. The best answer would be digital rectal examination along with PSA. Very good. Digital rectal examination along with prostate specific antigen. So if both of these are together in the option, then that would be the single best answer. Okay. So screening के लिए screening test of choice for prostate cancer is usually digital rectal examination on which you will find an enlarged prostate along with the serum levels of prostate specific antigen. What is the investigation of choice? Investigation of choice. You can go through the natural orifice and take a biopsy. So therefore, the investigation of choice would be a ultrasound guided. It would be a ultrasound or CT guided transrectal prostatic biopsy. It would be a ultrasound guided transrectal prostatic biopsy. It would be a ultrasound guided transrectal prostatic biopsy. Please remember this. Okay. Old man with back pain in prostate or BPH. In old man patient presents to you with back pain, as I told you always, the first differential diagnosis is always multiple myeloma. ठीक है, अगर वो rule out होता है, no such symptoms are seen, then definitely BPH is much more common as compared to prostate cancer. ठीक है. So important, please tell me, what is the sentinel lymph nodes? The sentinel lymph nodes. Please remember the sentinel lymph nodes which are there. The sentinel lymph nodes, those are your obturator lymph nodes. Sentinel lymph nodes for prostatic cancer is your obturator lymph nodes. If I talk about the treatment of localized prostate cancer or advanced prostate cancer, if it is a localized prostate cancer, then what should be done? If it is a localized prostate cancer, as I told you now, localized prostate cancer, it is a radical prostatectomy. If it is a localized prostate cancer, it is a radical prostatectomy. If it is a localized prostate cancer, it is a radical prostatectomy. It is a radical prostatectomy. Important है, ठीक है, याद रख लेना. Then next, if it is advanced prostate cancer, as I told you now, if it progresses further, then definitely it is only hormonal therapy. If it is advanced prostate cancer, then it is hormonal therapy. Anti-androgens are usually given to the patient. Anti-androgens to decrease the size of the prostate. Then what is this procedure called as? ये ऐसी image आ सकती है. When we are going by the urethral orifice and then we are resecting something with the help of a laser. So this is the transurethral resection of prostate. This is a transurethral resection of prostate, also known by the name of McCarthy's TURP. Also known by the name of McCarthy's TURP. That is a McCarthy's transurethral resection of prostate. Usually a surgical management for BPH. Usually it is a surgical management for BPH. So drug of choice for BPH is tamsulosin. It is for dilatation of your smooth muscles of the urethra, and therefore the patient's urinary problems would be solved. But for definitive management, you need to perform a McCarthy's TURP, that is McCarthy's transurethral resection of the prostate. If I talk about this image over here, you can see which type of lesion. You can see osteoblastic or osteoclastic lesions over here. These are osteo whitish regions दिख रहा है CT पे. So definitely these are osteoblastic lesions. These are blastic lesions. As we have discussed, metastasis from cancers usually occurs to the spine, mainly to the lumbar vertebrae, and that occurs by the Battison's plexus of veins. That usually occurs by the Battison's plexus of veins. But most of the times it is an osteolytic lesion. Most of the times it is an osteolytic metastasis or osteoclastic metastasis. But osteoblastic metastasis agar dikh raha hai, then it is usually a case of osteoblastic metastasis is a case of osteoblastic prostate cancer. Osteoblastic metastasis is prostate cancer. These other types of other osteolytic lesion. Here you can see osteoblastic lesion. Site of prostate cancer usually lumbar vertebrae by the Battison's plexus of veins and osteoblastic metastasis. No issues with this. Please remember this. Then next, talking about hernia, last topic for today. and will complete surgery. Most common hernia, jaldi se agar ye padha hoga, I hope so all of you have read this. Hernia is important, and we'll discuss it in a short manner, jaldi. Most common type of hernia, please let me know. Most common type of hernia, anybody? So the most common type of hernia is usually, very good, it is the indirect inguinal hernia. Most common type of hernia is the indirect inguinal hernia. Okay, most common type of hernia is the indirect inguinal hernia. Indirect inguinal hernia. Most common hernia in elderly patients. Most common hernia in elderly patients, jaldi. Most common hernia in elderly patients, it is the direct inguinal hernia. Very good. Most common hernia in elderly patient is the direct inguinal hernia. Most common hernia in elderly patient is usually a direct inguinal hernia. So hernia, I hope all of you are quite aware, it is due to a weak wall. Okay, so it can be a weak abdominal wall or a weak inguinal wall, due to which what can happen, the contents of the intestine can just come out. Okay, the contents of the intestine can just come out. Okay, that is what is a the contents of the intestine can directly come out. Okay? So please remember, in most common hernia in elderly is usually a direct inguinal hernia which comes out from the weak abdominal wall. Okay? Most common hernia in females. Most common hernia in females. I need to listen to this answer from most of you. Most common hernia in females. Very good, Jayashri. It is the indirect inguinal hernia. Most common hernia in females is the indirect inguinal hernia. Please remember, whether it is a male or a female, the most common type of hernia is the indirect inguinal hernia. जिनको भी femoral लग रहा है ना, प्लीज दिमाग से निकाल दो. What is the statement? Teachers give a statement, that is what most common hernia in males and females is indirect inguinal hernia. But if they ask you which is the most common type, but if they ask you which sex is more commonly affected with femoral hernia, then the answer would be females. Okay, so please remember, femoral hernia is more common in females, but it is not the most common type of hernia in females. Most common type of hernia in females is the indirect inguinal hernia, but femoral hernia is more commonly seen in females. Okay, femoral hernia is more commonly seen in females. No issues with this. If I talk about the NIHS classification now, if I talk about the NIHS classification of hernia, ठीक है, NIHS classification of hernia, class 1 and class 2 is usually, class 1 and class 2 is usually the, class 1 and class 2 is the indirect inguinal hernia. Class 1 and class 2 is the indirect inguinal hernia. Class 1 and class 2 is the indirect inguinal hernia. Class 3A is the direct inguinal hernia. Class 3A is the direct inguinal hernia. Class 3A is the direct inguinal hernia. Class 3B is, class 3B is, jaldi, class 3B is the, class 3B is for both, that is direct as well as indirect inguinal hernia. Okay, class 3B, B for both, that is direct as well as indirect inguinal hernia. Class 3C for the femoral hernia. Class 3C for the femoral hernia. Class 3C for the femoral hernia. And class 4 for the recurrent hernia. Class 4 for the recurrent hernia. No issues with this. This is the NIHS classification of hernia. If I talk about indirect inguinal hernia and direct inguinal hernia, what is the landmark? What is the landmark to differentiate indirect inguinal hernia and indirect inguinal hernia and a direct inguinal hernia? Jaldi se. What is the landmark to differentiate which hernia is medial to this landmark and which hernia is lateral to this landmark? So the landmark is the inferior epigastric vessels. Okay, the landmark to differentiate between an indirect inguinal hernia and a direct inguinal hernia is inferior epigastric vessels. So indirect inguinal hernia is lateral to the inferior epigastric vessels. Indirect inguinal hernia is lateral to the inferior epigastric vessel, whereas direct inguinal hernia is medial to the inferior epigastric vessel. Direct inguinal hernia is medial to the inferior epigastric vessel. Then which is the landmark to differentiate between the indirect hernia? Which is the landmark to differentiate between an inguinal hernia and a femoral hernia? The landmark to differentiate between the inguinal hernia and femoral hernia. This question had come multiple times. Landmark to differentiate between the inguinal hernia and the femoral hernia. Landmark to differentiate between inguinal hernia and femoral hernia. It is the pubic tubercle. It is the pubic tubercle. So please remember, usually inguinal hernia would be medial and above and medial to the pubic tubercle. Above and medial to pubic tubercle is inguinal hernia. Above and medial to pubic tubercle is inguinal hernia. Whereas below and lateral to pubic tubercle is femoral hernia. Below and lateral to pubic tubercle is the femoral hernia. Okay. Then these are the various types of hernia, as you can see over here. These are the various types of hernia. If it arises from the midline, if this hernia arises from the midline, okay, this is actually called as the linea alba. Okay, this is what is called as the linea alba in this patient, then this is actually a epigastric hernia. If it arises in the epigastric region, okay, usually from the midline, that is linea alba, it is nothing but a fat which is coming out. Okay, it is nothing but a fat which is coming out from the linea alba, and that is what is the epigastric hernia. That is what is the epigastric hernia. Then next one you can see at the lateral border of the rectus abdominis. At the lateral border of rectus abdominis muscle, which hernia is seen? Spigelian hernia. At lateral border of rectus abdominis, which hernia is seen? Spigelian hernia. Then at the level of umbilicus, it is the umbilical hernia. At the level of umbilicus, it is the umbilical hernia. Umbilical hernia is usually present at birth. Okay? Then next, if there was a previous surgery which was performed in this patient, and now as definitely we know not 100% strength is regained after a wound or after a cut. Okay, 80% of strength is there. But if sometimes the strength is not regained properly, then there would be a weak abdominal wall, and at the level of scar or at the level of cut, there can be an incisional hernia. There would be an incisional hernia. Then here you can see at the level of inguinal region, you can see a swelling. That is what is an inguinal hernia. So the most common symptom of hernia is usually inguinal swelling. Most common complaint would be a inguinal swelling in this patient. Next, if I talk about this hernia, which is below and lateral to the pubic tubercle, it is a femoral hernia, which is more common in females. Femoral hernia, which is more common in females. Now, please let me know which are the hernias which more commonly strangulate. Which are the hernias which more commonly strangulate? Please let me know. This is important. The hernias which more commonly strangulate are. Strangulate means there would be decreased blood supply. Strangulation means there would be decreased blood supply to the contents of the hernia. I hope all of you are quite aware. Usually, if there is a defect in the abdominal wall, definitely the contents of the abdomen will come out. Okay, so it can be an intestine or anything. It can be intestine, it can be any other organ. Okay, so please remember, usually it will have a hernial sac and there would be hernial contents, right? So usually these hernial contents, if there is a very narrow opening, they are at a higher risk of undergoing decreased blood supply, that is ischemia, and therefore there can be gangrene as well. So please remember, among inguinal hernias, if you ask me, then definitely it is the indirect inguinal hernia which is more at a risk. Why? Because indirect inguinal hernia comes from the deep as well as the superficial inguinal ring. Okay, so inguinal indirect hernia comes from the narrow portions like the deep and the superficial inguinal ring, whereas direct inguinal hernia directly comes from the abdominal wall. Direct inguinal hernia directly comes from the abdominal wall, so there are less chances in direct inguinal hernia to strangulate. ठीक है, but overall if I'm asking, indirect में strangulation इतना common नहीं है. Overall strangulation is most common in which types of hernia? Overall strangulation is most common in which types of hernia? Please remember, it is the femoral. Strangulation is more femoral hernia. It is also more common in incisional hernia. It is also more common in incisional hernia, or it is also more common in Spigelian hernia. It is also more common in the Spigelian hernia, which is at the lateral border of the rectus abdominis. Okay, so femoral, incisional, and Spigelian hernia are at a more risk of strangulation. No issues with this. If I talk about the hernia, okay, if I talk about the if I talk about the indirect inguinal hernia, so indirect inguinal hernia can be of various types. Okay, indirect inguinal hernia can be of various types. If the hernial sac is only up to the level of the superficial inguinal ring, if the hernial sac is only up to the level of superficial inguinal ring, then this is called as a bubonocele. Okay, this is called as a bubonocele. This is called as a bubonocele. If the hernial sac is at the top of the scrotum, if the hernial sac can be palpated at the top of the scrotum, it is called as a funicular hernia. It is called as a funicular hernia. Whereas if the inguinal sac is reaching till the bottom of the scrotum, if the inguinal sac is reaching till the bottom of the scrotum, it is called as a complete inguinal hernia. So jaldi say inguinal hernia or indirect inguinal hernia to be specific. These are of various types. If the hernial sac is till the superficial inguinal ring, bubonocele. Till superficial inguinal ring, bubonocele. Till the top of the scrotum, funicular. Till the top of the scrotum, funicular. And till the base of the scrotum, complete inguinal hernia. No issues with this. Now let me know about the treatment. Jaldi se. So let me know about the treatment. First of all, please, can anybody tell me, for a clinical examination of hernia, we can do, first of all, we need to check for two conditions. First is the reducibility of the hernia. First is the reducibility of the hernia. That means we will ask the patient to lie down and we will try to reduce the hernial contents back into the abdominal cavity. That is what is the reducibility of the hernia. And second, we need to check for the cuff impulse. Second, we need to check for the cuff impulse. Please remember, in a strangulated hernia, the cuff impulse would be absent. In a strangulated hernia, the cuff impulse is usually absent. Yaad rakho, okay? So cuff impulse should be present and reducibility should also be present. Okay, so this type of hernia has a better prognosis. This type of hernia usually has a better prognosis. Okay, otherwise there is a high risk of strangulation if reducibility is not there or if the cuff impulse is not present. Okay, yaad rakhna. Now please tell me, treatment of hernia is definitely hernioplasty. That means we will open up the sac, we will put the contents back into the abdominal cavity and close the abdominal cavity. That is what is the treatment of choice. So for open, either we can do a open surgery or we can do a laparoscopic surgery. Okay, we can do a open surgery or a laparoscopic surgery. Important. Okay. So what is the open surgery called as? Important. Please remember what is the open surgery of hernia called as? It is called as the Prolene mesh hernioplasty. Okay, so nowadays we don't only reduce the contents. Okay, we don't only reduce the contents, rather we will also use this mesh made up of Prolene, because there are high chances of recurrence in cases of hernia. बहुत ज़्यादा high recurrence होता है in cases of hernia, and therefore we use this Prolene mesh. We will reduce the contents, we will place this Prolene mesh over it so that recurrence is not seen. Okay, so best material used for mesh is usually the Prolene. Best material used for mesh this Prolene used for hernioplasty. So Prolene mesh hernioplasty is the open surgery which is performed. Okay, so Prolene mesh hernioplasty is the open surgery which is performed, whereas laparoscopic surgery can be a TEP or TAP. Okay, laparoscopic surgery can be a TEP or TAP. What do we mean by TEP? TEP means a total extraperitoneal repair. TEP means a total peritoneal repair, whereas TAP means a transabdominal preperitoneal repair. TAP means a transabdominal preperitoneal repair. Most common nerve injured. Please tell me the most common nerve injured in cases of, okay, most common nerve injured in cases of open surgery and laparoscopic surgery. ये question था. Most common nerve injured in cases of open surgery and laparoscopic surgery. जल्दी से. I'm not able to see your answers. I'm not sure why. Or you are not answering. Most common nerve injured in cases of open surgery or laparoscopic surgery. So the most common nerve injury in cases of open surgery. Most common nerve injury in cases of open surgery is the inguinal nerve. It is the most common nerve injury in cases of open hernioplasty is ilioinguinal nerve. Most common nerve injury in open hernioplasty is the ilioinguinal nerve. Whereas the most common nerve injury in cases of laparoscopic surgery is the lateral cutaneous of thigh. Most common nerve injury in laparoscopic cutaneous, it is the lateral cutaneous nerve of thigh. And lateral cutaneous nerve of thigh, if it is injured, it will lead to which syndrome? Anybody? If the lateral cutaneous nerve of thigh is injured, definitely there would be decreased sensations on the lateral aspect of the thigh. It would have the congenital hernia, as I told you already, congenital hydrocele and congenital hernia are treated by the same surgery, and that is herniatomy. They are treated by herniatomy. They are usually treated hernia. No issues with this. Now, so hernia important है, याद रख लेना इतनी चीजें at least. Okay. And one more thing, last differentiate between direct inguinal hernia and a femoral hernia. We will keep 3 fingers on the superficial inguinal ring, then on the Hasselback's triangle, and third on the femoral canal. And then we will ask the patient to cough every time. Whenever the abdominal cuff, okay, we will ask the patient to cough every time whenever we lift a finger. Okay, so whenever our finger is lifted from whichever position, that means the patient is having that particular hernia. Okay, this 3-finger test is also known as, anybody? This 3-finger test is also known as to differentiate inguinal, indirect inguinal, direct inguinal, and femoral hernia. 3-finger test is also known as the Siemens test. 3-finger test is also known as the Siemens test. 3-finger test is also known as the Siemens test. And direct inguinal hernia, the most common site, as I told you right now. Okay, the most common site is known as the Hasselback's triangle. Most common site for direct inguinal hernia is the Hasselback's triangle. Most common site for direct inguinal hernia was the Hasselback's triangle. It was having, here you can see there was a hernia from the umbilical region. Okay, and it was with the intact peritoneal sac. So there is a peritoneal sac which is present, and in that the contents of the hernia can be anything ranging from liver to intestine. Okay, so any abdominal organ can be present. Like thing is peritoneal sac. The origin is from the umbilical. And this condition is called as, anybody? This is usually associated with Beckwith-Wiedemann syndrome. This is usually associated with Beckwith-Wiedemann syndrome. Okay? This condition where there is an intact peritoneal sac and the contents can be liver or intestine, and it is arising from the center, from the umbilicus. Very good. It is known as the omphalocele. So this condition is known as the omphalocele. Whereas another condition, okay, which arises from the paraumbilical region, arises from the para-umbilical region. It arrives in the para-umbilical region and it does not have a peritoneal sac. It does not have a peritoneal sac or a peritoneal covering. And the content can only be intestine. And the content can only be intestine. Such condition is called as gastroschisis. Such condition is called as gastroschisis. So definitely the prognosis in cases of gastroschisis would be much poorer. Okay, the prognosis in gastroschisis is much poorer usually, but these patients respond well to surgery. Okay, gastroschisis wale omphalocele se, because omphalocele mein the defect is huge. Next, what is this condition? Here you can see a ulceroproliferative is known as the gingivo-buccal sulcus. This is known as the gingivo-buccal sulcus. So ulceroproliferative growth in gingivo-buccal sulcus is more likely a case of oral cavity cancer. This is more likely a case of oral cavity cancer, right? So please remember, ulceroproliferative growth in the gingivo-buccal sulcus is mostly due to oral cavity cancer. Okay, so if they ask you the most common site for oral cavity cancer in India, the answer is gingivo-buccal sulcus. Most common site for oral cavity cancer in India, the answer is gingivo-buccal sulcus. Most common site for oral cavity cancer in India, then it is usually the gingivo-buccal sulcus. But if they ask you the most common site for oral cavity cancer overall, most common site for oral cavity cancer overall, answer would be most common site for oral cavity cancer overall. If there is a delay, I'm not sure, I'm not getting the answers on time. If there is any, very good, very good. Then it is lateral border. Remember, common site of oral cavity cancer overall worldwide, it is the lateral border of tongue. It is the lateral border of tongue. And next, what is this condition? This is a cyst. Okay, definitely this is a cyst due to accumulation of some fluid. Okay, so this fluid which is accumulated is a mucoid retention cyst which formed the ranula. Important image है, आ चुकी है पहले, ठीक है, ranula. And ranula, as we know, on trans elimination it will be brightly elimination positive, trans elimination ranula, because it is a mucoid retention cyst itself. And what is the treatment? Anybody? What is the treatment? Jaldi say. For ranula, what is the treatment? For ranula, what is the treatment? Very good. So please remember, either we can perform a excision. Okay, either we can perform a excision or we can perform a marsupialization. Okay, we can perform a marsupialization. Rates of recurrence are less common with marsupialization. Rates of recurrence are less with marsupialization. Open up the ranula, drain it, and then we will evert the edges. That is what is marsupialization. Marsupialization is also a treatment of choice for a posterolateral swelling in the vagina in females. That excision is better. Okay, so actually better. We try to perform excision if it's size. If it is very large in size, then we perform marsupialization. Okay? If it is very large in size, then we perform marsupialization, because excision would not be very much. Excision is not feasible in this condition if it is a very large ranula. Short ranula, so excision definitely is the best choice. Treatment of choice for this condition. What is this condition? Last time yahan aaya tha December mein, a child was having a cyst over here, a cystic swelling over here. In December examination this time. It can be anywhere on the body. It can be the hands. It can be the scalp. Anything. Okay, anywhere. Dermoid cyst. They give you any history. They would just give you this swelling. This is a dermoid cyst. Okay, this is a dermoid cyst, and the treatment of choice would be a excision surgery. The treatment of choice would be with this. Most common parotid tumor is pleomorphic adenoma. Parotid tumor is adenoma. Most common parotid tumor is pleomorphic adenoma. Different size and shape of cells would be seen. And what is the treatment of choice for pleomorphic adenoma? Treatment of choice for pleomorphic adenoma usually. Treatment of choice for pleomorphic adenoma. Apart from that, usually in salivary glands, we can also see a Warden's tumor. It is also important. Okay, we can also see a Warden's tumor. Important. Okay, so Warden's usually bilateral zyada hota hai, whereas this pleomorphic adenoma is mostly unilateral. Okay, what is the treatment of choice for both these tumors, whether it is a Warden's tumor or pleomorphic, which in cases of superficial, the most common nerve injury is a most common nerve injury superficial excision hai. Remember parodonticectomy, because invasive, don't mark it as a radical something. It is only a superficial parodonticectomy. Okay? When nerve injured is very good. Branch of the facial nerve. It is branch of the facial nerve which is known as the auriculotemporal nerve. And it would lead to which syndrome? If it is injured during parodonticectomy surgery, important from ENT point of view, it would lead to which syndrome? Gustatory sweating hogi patient mein. Whenever the patient eats spicy foods, there would be sweating from the auricular area, or they're sweating from the cheek, there would be flushing, redness hoga. So this is known as which syndrome, anybody? This is known as the Frey's syndrome. This is known as the Frey's syndrome. Okay, self-limiting hota hai. Hernia ka last type hai. If hernia can be decided on the content. Okay. Omentum is the content of hernia. It is called as omento. The content definitely is the content. Then it is called as the, and when, remember guys, abhi मैं बता नहीं problem आ रहा है, so I'll complete कुछ ज़्यादा नहीं है. Just be attentive. It's called as omentocele or epiploccele. If intestine is the content, it is called as enterocele. If Meckel's diverticulum is the content, it is called as Litter's hernia. If appendix is the content, it is called as Ammian's hernia. Appendix ho to Ammian's hernia. If a loop of intestine is the content, it is called as Richter's hernia. If loop of intestine is the content, it is called as Richter's hernia. If W-shaped loop of intestine is the content, if a W shape with hydrocele is there, hernia. Please remember, hernia with hydrocele is usually called as a Gibbon's hernia. Okay, hernia with hydrocele is usually called as a Gibbon's. ठीक है, कोई दिक्कत नहीं है. So yeah, so we have covered surgery. ठीक है. यार problem आ रहा है इसमें. Okay. If omentum is the content, it is called as omentocele or epiploccele. If intestine is the content, enterocele. If appendix is the content, it is called as Ammian's. If appendix is the content, it is called as Ammian's hernia. If Meckel's diverticulum is the content, it is called as Litter's hernia. Okay. If hernia is present along with hydrocele, if there is hernia with